My most heartfelt thanks to each and every one of you for being here with us today. Today's event launches a national dialogue. But our time here today is not only launching a dialogue, we will take action, together. Our time here today serves as a call to action. Action from each of us in this room, but also action from others outside of the room and across the country, people that you and I will engage in our common goal of combating drug-impaired driving. We are here because I learned from you, from many of you, and you know who you are, many of you and many folks outside this room, of the growing evidence of drug impairment on our nation's roadways, presenting increasing risk to the health and safety of our neighbors, our friends, and our families. NHTSA, the National Highway Traffic Safety Administration, is a safety agency. It's not just our responsibility to lean and address driving under the influence of alcohol and other factors, but also of drugs. It's our mission and it's our obligation to protect Americans and to protect our roadways and to save lives. So that is why we've asked each of you here today. Thank you for being here. We've invited you to help put together the pieces of this puzzle, and it is not a simple puzzle, I'm sorry to say, but we in this room, I and the people of the National Highway Traffic Safety Administration, are committed to saving lives, to preventing injuries, and to reducing the costs of automotive crashes from all causes, but also drug-impaired driving. We must start by raising awareness, by echoing and amplifying those messages that some of you have already been developing and deploying, to share those messages with our partners, to share best practices, to learn from one another, to set a vision and take action. Together, we will begin to chart a course towards safer roads. So enough, let's get started. I'd like to introduce Dr. Terry Zobek, the Acting Associate Director for Policy, Research, and Budget at the Office of National Drug Control Policy in the White House. That office, as many of you know, leads and coordinates the nation's efforts at reducing drug use and its consequences. Dr. Zobek oversees the production of the National Drug Control Strategy, the administration's blueprint for addressing international, interdiction, interdomestic law enforcement, prevention, and treatment activities to reduce drug use and its consequences, such as drug-impaired driving. As the acting deputy director of that office, he is responsible for policy, implementation, and assessment in areas of public health, prevention, treatment, and recovery. He's been with that office since 1996, and prior to that federal service, he was a substance abuse researcher for 13 years in the private sector, managing contracts for federal clients, including the ONDCP, the National Institute on Drug Abuse, the National Institute on Alcohol Abuse and Alcoholism, and the Substance Abuse and Mental Health Services Administration. He received his PhD from the University of Tennessee, and his willingness to join us here today is an indication of his shared interest in our combining forces, in our collaboration across all members of the federal family, state, local, community governments, stakeholders, citizens, friends, and neighbors. We are starting a movement here today, Dr. Zobek being the beginning of that movement, but I thank you for your contribution today. We have work to do ahead of us today and in the days ahead, but let's start. Dr. Zobek, thank you for being here. Thank you.
Thank you, Administrator King, for the nice welcome, and good morning to all of you. It's a real pleasure for me to be here to speak to all of you and to represent ONDCP, and particularly our new acting director, Jim Carroll, who just came on board within the past 3 weeks. And I've had a chance to speak to him about this issue already, and he's already scheduled me for a meeting to give him a back brief on today's events tomorrow, and he's very, very interested in this issue. As Heidi mentioned, ONDCP has responsibility for coordinating the activities of all the federal departments and agencies that have some drug control function. And This issue has been of importance to us for many years. I started my career out in Washington working on impaired driving issues, and about almost 10 years ago now, when NHTSA released the findings from the 2007 roadside survey, this was around December of 2009, this brought me back into the issue. And our director at that time was Gil Kurlikowski, who had spent his entire career in law enforcement. When he got the results of this survey, it really had an effect on him. He had seen the carnage on the roads from drunk driving, and he was, as we all were rather alarmed at the degree of drug driving going on. I'm sure you'll hear more about that survey, but just to give you the highlights, it found through blood and oral fluid tests that 12.4% of weekend nighttime drivers tested positive for either an illicit drug or a prescription medication that can impair driving. And of that, marijuana was the most commonly detected drug at about 8.6%. This caused us to declare this as one of the priorities for the federal effort on combating drug problems. This became one of the cornerstones of the strategy. And as part of that, we requested NHTSA to accelerate their schedule for doing the next roadside survey, because we had established a goal of reducing drug driving by 10%, and we needed another data point on that. And I'll be eternally grateful to NHTSA for agreeing to do this and really accelerating what is a very, very complex and difficult logistically to manage survey. Unfortunately, when that survey was released, it was the 2013-14 survey, drug use among tested drivers had actually increased to 20%, and marijuana had gone up to 12.6%. And this just raised our concern, and it's very gratifying that the current administration continues to see that this is a top priority. And I'm very pleased to be continuing to work with NHTSA on this issue and to be here. And some of the things that the government has been doing and continues to do, I just want to briefly highlight those. We continue, marijuana from the federal perspective is still a controlled substance, a Schedule I controlled substance, and any use is considered to be illicit. And so we still support that and the per se laws that many of the states have. We also worked closely with many of the NGOs out there, particularly Mothers Against Drunk Driving, who are so instrumental in having a positive impact on drunk driving. We have been supporting the development of oral fluid guidelines for testing of oral fluids. The Substance Abuse and Mental Health Services Administration, which oversees that program, has developed these guidelines, and we're hoping that they serve as a catalyst for the industry to be able to develop a portable oral fluid testing device that can be used by law enforcement at the roadside. And we've seen tremendous movement in that in the past 5 years. We also supported the National Institute on Drug Abuse to do simulator research at the University of Iowa in cooperation with NHTSA. That over the last 3 years, Marilyn Hustis and her team have been issuing a series of reports that have been extremely helpful in moving the science forward on this issue. We also continue to support the Department of Transportation's drug recognition expert officers. And I'm sure most of you are familiar with the work that they do. And we've also supported the development of an online training program for advanced roadside impaired driving, the ARIDE program. And We've also supported a number of international symposiums on this issue. Bringing our international partners in on this are incredibly important. And the first one was in Montreal in 2011. The most recent one was in Lisbon last year. So we look forward to continuing that work. We get so much important information and research from our international partners. So this issue continues to be of a primary focus. I'm sure it's going to be included in the administration's inaugural National Drug Control Strategy, and I look forward to continuing to work with the department, NHTSA, and all of you. So thank you.
Presentation. Thank you so much, Dr. Zobek. Your support means a great deal to all of us. Again, I think everybody in this room is going to be a part of sharing the message and the mission with the 328 million or so other people in the country, but your leadership is very, very much an important part of that. I'm going to speak for a few minutes before introducing our next speaker. Several of you in conversation, maybe over dinner this past week, maybe in phone calls or in some of the preparation meetings, have asked me, why now? Why did I find this passion for addressing drug-impaired driving? I told a few of you various stories. I told you that about 30 years ago I was in law enforcement, not for a long time, but long enough. I had the honor to serve in the state of California, and as an officer I felt very well trained and well equipped to identify the signs of impaired driving, to develop the probable cause to execute a safe vehicle stop, to assess the signs of alcohol impairment in a driver, to administer field sobriety tests, to document and to collect evidence and maintain chain of custody. I knew what to do as an officer. I knew what to look for, I knew what to do, I knew how to do it safely, and frankly, I knew how to get those drivers off our roads. I'm proud that I had a very good conviction rate when I did identify a drug-impaired driver. And frankly, I thought we were winning. My career moved on. I moved into other areas of policy. I moved into the private sector. I joined NHTSA about 5.5 months ago, almost 6 months now. One of the first things I learned here at the National Highway Traffic Safety Administration is something that all of you know too well. We have had an unacceptable increase in road fatalities. We have had a historic proportionate increase in deaths on our highways due to traffic crashes. Auto collisions killed, as you well know, thousands upon thousands of people. 2016 and 2015 increases larger than we'd seen in my lifetime. Of course that would cause me to reflect, as it causes you to reflect, like what are we doing? After years and years of decreases in roadside fatalities, we see an increase. My first instinct is to go to the data. Guess what? We don't have great national data on drug-impaired driving. How can that be? Look at all the work we put into our highway traffic safety data. There's work to be done, that's obvious. In conversation with you, learning about what we're doing, it's clear that there's much we can learn from one another. You have heard, some of you in conversation with me, that I have a haunting discomfort with the deaths on our roadways, deaths that seem to be forgotten as soon as the highway is cleared. Some of you heard me tell the story of a particular accident where a young couple died in an auto crash into a tree. They were impaired, returning home from a party. Hours later, with the sun shining on the water, beachgoers stepping over the scene of the crash on their way to the beach, not realizing the tragedy that had occurred hours before. I fear that we are like the people stepping over that scene, not realizing what's happening on our roadways. And now I'm at NHTSA. I have the opportunity to bring you here together to seek your help, to take your advice, and to help us all move forward. That's where I get the passion. It's from you and from seeing the need on our roadways. So I've learned from you not only about the risks on our roadways, but I've also learned about the successes. I've learned about the epidemic, but I've also learned about the tools. I've learned that There are efforts to improve public awareness, largely at the local level now. I've learned about the education of our law enforcement officers from A-RIDE and DRE. I've learned about the fantastic toxicological protocols that are being developed so that we can actually assess the presence of drugs. I've learned about the science that tells us about impairment. You've convinced me, you have convinced me, and all of us at NHTSA, that it is time to take action now. It is time to save these lives. So today is a call for action. We will set both short-term actions and a long-term vision. And frankly, and terrifyingly, I don't know what that long-term vision is, but you and I, you and the people of NHTSA in the floors above, we're going to write it together. It's a time for action to set a long-term vision for what we're all going to accomplish to combat drug-impaired driving. All of us here in this room today will craft a vision for a nation without drug-impaired drivers on our roads. We will take action together. But first, we'll start with some learning together. We're going to start with Officer Jermaine Galloway. His Tall Cop Says Stop presentation named Hide in Plain Sight. He will present for about 35 minutes. He's a nationally recognized presenter that I'm sure you will all enjoy, a national award winner. He's a great resource for those involved in prevention, education, and in enforcement, which, by the way, is the first step of the journey, education. He was an Idaho law enforcement officer from 1997 to 2015 and has more than 16 years of experience in alcohol and drug education, enforcement, and prevention. He currently over 40,000 students in his classes, attendees in his classes each and every year, so he certainly knows how to get the word out, and he dedicates thousands of hours of his time to community scans, research, and substance abuse identification in large and also in rural communities across our country. He provides national training to coalition members, law enforcement, educators, youth, counselors, probation, treatment, health professionals, judges, university officials, and community members. He was formerly a member of the Idaho Impaired Drivers Task Force. He's also an Idaho Police Officer Standards and Training Board Certified Instructor and holds Bachelor of Arts from the University of San Francisco. Clearly a role model for the work that is ahead of us. I am very excited to welcome Officer Jermaine Galloway. Thank you.
Mic on? Thank you. Can you guys hear me? There we go. Thank you guys for having me. I appreciate you guys taking the time to have me out here and take the time to sit through this presentation. So I know I have about 35 minutes, so I'm going to kind of start diving right into things. My goal today is to show you what we are dealing with on the streets, what we are seeing, to have a real true understanding of all these things we're running into and how they all associate together. Now, with that being said, I have about 30 minutes to give you a training that I could keep you here for 2 days. So I've kind of shrunk it down slightly, okay? But a lot of things to talk to you about. Now, just so you know, I am a walker, all right? So I will not be behind the podium. I do move, I do walk. Many of you guys have sat through my trainings. I like to look at the screens and move. So let's start diving right into things, okay? A couple disclaimers that I put up right at the beginning is this. No one thing means any one thing. Everything I'm going to talk to you about is person specific, which is what makes some of these things so difficult. We can't just throw everyone in the same bucket and say, this is the one issue all the time with every person, every way, right? Because we're seeing so many different things on the street from so many different people in so many different ways. And the problem is, the big problem is going to be, or already is education, and then leading into more enforcement, more education, more enforcement. But I'll talk about that, and I'm going to kind of walk you guys through that, showing you what I call the big bowl of drug spaghetti here, okay? So I have a story for you first. What you're looking at here is a photo from last September, okay? And here's what happened. I was doing a training in Texas. I was in the state of Texas, and I was doing a training very similar to this. I was doing a training on drug trends and drug impairment and drug impaired driving. So my cell phone starts blowing up. My cell phone starts calling, and it's my wife. Okay. Now, my wife frequently calls me when I'm starting presentations. So that's nothing new. She frequently texts me when she texted me 10 minutes ago. Okay. So she frequently texts me when I'm starting presentations. But in this case, the phone's ringing and ringing and ringing. And of course, I send it to voicemail, and then she calls back. And she knows I'm doing a training. So luckily enough, I had started a video. So the video is about 3 or 4 minutes long. So I go to the back of the room so none of the class attendees notice, and I take the phone call. So when I take the call, she says, our son Jalen was just in a car wreck. Okay. Now, Jalen, a little side note, I'm 6'9", if you guys didn't notice. All right, Jalen's 6'7", basketball player, had just committed to play college basketball at a NAI school about 30 miles away. So, as part of his reward, we had given him a car. I said, hey, you get a scholarship, you're saving me a lot of money, we're going to give you a car. Okay. So, we'd given him a car. So, she says, Jalen's just in a car wreck because Jalen goes and he trains for basketball in the morning, goes home, showers, goes back to school. Okay, so I'm thinking, how is it 9 a.m. and my son is in a car wreck? And we only live about 2 miles from the school. Well, unfortunately, what you're looking at is Jalen's car is the black SUV on the left, and the car on the right, that was a driver who was high on methamphetamine and in possession of methamphetamine. Okay, so as my son is going back to school after training, as I am giving a drug presentation, my son is hit by a drug-impaired driver. Okay, totaled both vehicles. Now the side note is Jalen only had that car for about 30 days. Okay, so understanding, guys, that when we talk about how this affects everybody, this is not a those people issue. This is not an issue for all of those. This is an issue for all of us. This is an issue that impacts every single person in this room because as you're sitting here, your families are where? Out on the roadways. Okay, so understand the impact that we're talking about and how this really works, right? Now, today, some of the things I'm going to touch on with you guys is this. Sorry, the clicker's a little bit slow here. But I want to talk to you about a lot of different influences we're seeing and how this actually impacts drug-impaired driving. We're going to talk about the perception, right? Now, not necessarily the perception in this room, but what about, I tell people my airplane conversations. When people say, what do you do when I'm sitting on an airplane, because I train, so obviously I fly a lot, and they say, what do you do? I say, well, I do drug presentations and alcohol presentations, which leads right into all the things that they see and read about in the newspaper, right? And what is many of their perceptions? Well, this is a Friday, Saturday night issue. Is this all really a big deal? Is this all really a problem? Does this really affect anyone, right? We know it's not a Friday, Saturday night issue because my son was hit during the week at 9 a.m., right? So when we start talking about this, there is a perception among the public that is this really a big deal? You know, just if you get a little bit high, is that really a problem? Okay? And this is something that we're going to have to overcome. I'll show you real street level examples of what we're seeing and what's going on. I'll give you examples from law enforcement, from our DREs. You already heard them referenced once this morning, our drug recognition experts. I train a lot of those guys, and it's great because a lot of those guys send me emails back, as do our standard law enforcement, as do school teachers and nurses. You'll see a couple of those emails because I don't just want to tell you about them, I want to show them to you, okay? So also, I mentioned the big bowl of drug spaghetti. How is everything associated? How do all these things associate in? So we'll talk about that. More availability means what? Means more use. Okay, it's pretty simple. A lot of times in my classes I tell people, guys, we don't have to wait for the data to come out. Use your common sense. If something's more available, does that mean people use it less? Okay, so again, when we start talking about the drugs we see on the streets, we'll dive into that. Also, high in plain sight. How does all this stuff tie in? And I want you guys to ask yourself a couple questions. Would this stuff stand out to you? I just plugged a few photos here, but just to give you an idea, top left corner, that says sugar, that's actually marijuana, okay? And that surprises a lot of people because of today's forms of marijuana. Top right corner, I want you to ask yourself, would that have stood out to you yesterday? Okay, that's a reference, peace, love, unity, respect, very popular in the designer drug culture. Very, very popular in the designer drug world, okay? Something that we see all the time, right? And bottom left corner, obviously a vape pen. And all these photos I took, but that vape pen that you're looking at is actually loaded up with marijuana. We're gonna talk about ease of use, ease of availability, and how that impacts our roads. And then bottom right corner, what you see there is you're looking at an SUV, bottom left corner, that window there, you see kind of a little image. It looks like it's a tilted styrofoam cup. That's actually a cough medicine reference, okay? Promethazine with codeine, that's a cough med reference you're looking at. So now we're looking at stuff, and again, I don't pull these photos from the internet. I don't go to the deepest, darkest, corners of our society. This is stuff that you're looking at every day, okay? Stuff that you see that promotes that pro-drug culture, right? Now, understand that today's drug culture does not look like drugs. It is very discreet. It will not stand out to you, okay? And that's one of the hurdles we have. All of us do. Everybody in this room, no matter what you do, this is the hurdle that we have, right? When you look at this logo, I want you to, and I'll zoom it in because it's a little bit hard for you guys to see probably. This is the bumper sticker of a car out in Washington State, okay? So now as you look at this bumper sticker, ask yourself a question. This morning, and now I'm assuming a lot of you guys took public transit, but let's assume that you drove, okay? So this morning as you drove here, would that have stood out to you as anything? Okay, would you have looked at it twice? Would you have maybe Google searched it? Because understand, this is what it means, okay? So when we're talking about down to smoke a bowl, down to smoke a blunt, we're talking about marijuana, right? Because this is the stuff we are seeing and what we're dealing with. And it is everywhere. And understand, it builds up that culture. It builds up that no big deal culture. It builds up that everything small culture. It builds up, is this really a problem culture? Okay, because it all ties in, right? It finishes with some of the people that we see who get impaired and get in wrecks and kill other people or kill themselves. But understand, where does it start? Okay, what's all the stuff we're dealing with? So, when you look at this here, guys, this is not just stuff we see on the street. This photo you're looking at right here is from a retail store, okay? And what I like to say, a youth-based store. Some people say, what's a youth-based store? I say it's a store that really 25 and under like to frequent. Okay, so the store that a lot of us don't go in, right? So now you look at this right here, you see some obvious references. You see marijuana pipes on the bottom, and all the way in the top right corner, you see marijuana socks, okay? So we see a couple blatantly obvious drug references that everyone recognizes. But when we talk about looking past the obvious, what's in between it? What's right next to it? What's around it? Okay? Because here is how our pro-drug culture starts to figure things out. So what you're looking at are some ball caps. Those ball caps in the middle you're just looking at have stash pockets in them. These are sold in every single state. So everybody represented in this room, these are sold in your state. Okay? Now, when we start looking at stuff like this, is this just something that we come across in retail stores, or how does this spill off onto our streets, right? So let's talk about this. This right here was down in kind of the southwest part of the U.S. So this was a traffic stop. So I'll read this out to you. For you guys in the back, you can't see it, okay? So this is from a trooper. I attended the hide in plain sight training on July 27th. On July 31st, I arrested a subject for possession of controlled substance. So I emailed him back and I said, hey, were the drugs inside the hat? Here's what his response was. Yes, sir, they were inside the hat. It took me a while to notice it since it was night. I saw the small crown logo on the left side and he identified it. This is what he's talking about. These are the photos, and that's the controlled substance that was in the hat. Okay? Now, when we go back, I want you to look at something. Let me go back a photo here. See if my clicker goes back. There we go. I want you to look at something. Look at the top right corner. Look at the sweatband of that hat. Okay? Look how it's all worn out. You know what that tells us? This individual has been wearing this hat for quite some time. And when you start thinking, and you start thinking like some of our drug seekers, here's what you have to look at. I just need to put something in that hat that will get me through the day. Enough, again, not selling, not dealing, but enough to get me through the day, right? Where I'm going to be using throughout the day just enough till I get back home, okay? And this is why all these little compartments and all these little things are so important to understand, right? This one came in from one of our DREs, so you've heard them referenced a couple times, drug recognition experts. Now, interestingly enough, these were back-to-back days, okay? So this was out of the state of Colorado. So day one, he basically assisted another trooper, okay, and who made a DUID arrest, right? And the first thing out of his mouth when he called me was, do you have any idea what lean is? This guy asked me, so the suspect said, are you taking my weed and taking my lean? Understand, this is what we're here talking about, right? The DUID arrest, okay? Are you taking my weed, taking my lean? What lean is, for you guys, I know some of you don't know, because I see some puzzled looks out there. Lean is a cough medicine reference. Okay, so lean is a cough medicine reference. But this is the terminology we have on the streets, because people don't say, sir, are you taking my promethazine with codeine today? Well, you'll never hear that, okay? So what you're going to hear are the slang level terms that people talk about. But actually the next night, look at what he says. Then the next night while I was in the jail, a city officer brought in a suspect, so the city officer didn't know, wearing one of those hats we just talked about. The suspect had already told the city officer that during the search, he missed a bag of prescription pills that were in the hat. Okay, and when we talk about even going back to our DREs, there's a major importance because these are our experts out there, right? But understand, a big part we have to understand is this: our street level law enforcement also depend on our DREs because they look at them as the experts too, which means they're going to be knee deep in a lot of this, even something that didn't originate with them. Okay, and so when we start diving into this, it's important for all of us to get this, but especially that group. Now, something I explain to people is availability of some of these drugs. A lot of you have heard about the dark web. We hear commercials about the dark web. I can tell you this, as a drug instructor who trains 40,000 people a year, I don't know anything about the dark web, don't know how to get to it, don't know how to navigate around it. I know nothing about it. And you know why? Because you don't have to go to the dark web to get every drug you want. Okay? Every drug you want is simply available through a Google search. As you look at this website here, it said discrete shipping, and they'll send you your favorite research chemical, i.e. synthetic drug. Okay, and some of the most lethal drugs, they were selling phenylfentanyl on this website, they were selling U-47700, known as pink on this website, they were selling it all, okay? But you don't even have to go there, you can also go just through Twitter, as you see right there, alprazolam, okay? This is the stuff that we're seeing which opens up that availability, which also ties into what we're seeing on our streets. okay? Because people can get it easier, a lot easier, right? So now we look at some of our friendly looking products. I call this the cutesy product, okay? Just something that looks like no big deal, because everything's no big deal until it becomes a problem, right? Now, when you look at this product, ask yourself, what drug, this was a street level drug seizure, what drug are you looking at? Okay, and here's your answer, you're actually looking at marijuana. Okay, now when we talk about today's forms of marijuana, we're going to start talking about how this ties into the issues we are seeing, the direct line issues we are seeing. Because when you talk about dabbing or marijuana concentrates or a concentrated form of marijuana, basically extracting the THC resins. Now extracting is a term that sounds kind of like, hey, I need a chemist to do that, right? Not really. Okay, a 14-year-old can extract. All right, you can watch a video online and you can extract. It's actually quite easy to do. So extracting those resins to make a product that doesn't look like a standard product. Okay, so again, the first level of this is training our folks up on really what they're dealing with. Because I'll tell you, a lot of people in all sectors of professionals who come across this that don't understand what dabs are, they think it's heroin. Okay, so that's the first thing they test it for, look at, they think it's heroin. Okay, but now, all different forms of dabs, and just so you know, BHO stands for butane hash oil, butane honey oil. That's what that term actually references. So when you hear people reference BHO, that's what they're talking about, okay? But how does this tie in? This was out of the state of Florida. So this was a DUID, traffic stop arrest out of the state of Florida, okay? The subject was high while driving, and what you're looking at is a vape pen, and the vape pen is just pulled apart, so it's kind of 3 parts, but it's all one pen. And in the bottom right corner, that's the bowl of the vape pen, and I know from the screen it's a little hard to see, but that vape pen is loaded with marijuana wax. The marijuana I just showed you, it's loaded with. What I've explained to people is marijuana waxes and concentrates and vape pens were the perfect marriage. Okay, because what happened was you had a product that could vape oils, or you could load oils in, and now you have an oil form of marijuana that's even more potent than green leafy herbal marijuana. So now you need to start thinking like a user for a second. This is the way I kind of explain it to people. If you are driving down the road and you're smoking from a traditional marijuana pipe and you're holding your hands like this, the universal symbol, right? People are either A, going to recognize you, or if you get pulled over, they're going to smell that. Okay, because you can get pulled over an hour and a half later. Every law enforcement officer in this room will tell you they've stopped cars where people say, I smoked weed 2 hours ago, and it was still a very pungent, strong smell when we stopped that car. Okay, but here's the kicker now. You load a vape pen with a high-quality vape pen with high-quality marijuana waxes or marijuana oils, it still puts off a little bit of an odor, but it's significantly less. Okay, so it's much less of an odor, but yet they get a stronger high. So what message is being sent on our roads? Don't use the 15, 16% glass pipe, smoke the 70% waxes. Okay, so now why would that be a surprise that now we're seeing an issue in the, with a rise on the one side? Right? Because again, if you understand the concepts of the drug itself and also how it reduces your likelihood to get caught, it makes sense that people would be moving to that while in vehicles. Okay, now, just a couple other forms of concentrates, just so you know, other forms of marijuana. This is marijuana you're looking at. This is a crystallized form of marijuana that you're looking at here, okay? And a lot of these different crystals and powders will work in vapes. As I explain to people, are vapes made for crystals and powders? No, they're not made for that. But can you make them work good enough to not get caught? Absolutely you can. Okay, and also it leads you to think now, would I buy a small little vape pen to load a crystal substance to then go sit on my couch and smoke that? That doesn't seem to make a lot of sense, right? So why am I motivated to buy that? Okay, so again, are we saying that that's what everyone's using it for? Of course not, right? Everything's person specific, but we have to understand what is going on. We have to understand street level what's going on, right? Here's another form too, just to give you an idea. These are marijuana tinctures. Okay, so marijuana tinctures, what you're looking at here looks like a little eyedropper bottle. This is mango flavored, okay, mango flavored marijuana. But here's a couple things I want you to look at, cherry and pineapple. But marijuana tinctures, you can take them directly or you can add them to your coffee, you can add them to your salad dressing, you can add them to your soup, you can add them to whatever. Okay, everyday products that you can add any type of, let's say 10 milligrams of oil to, you can add tinctures to, and now you've just infused it with the drug. Okay, so now when we start thinking about, again, the impairment we see on the roads, starts to make sense because it seems really easy, doesn't it? Doesn't it seem pretty easy just to get high and jump behind the wheel and go ahead and boogie on to wherever you have to be? Okay, again, this is what we're dealing with, guys. So this one, pretty interesting, called a water tincture. Okay, your sativa strain is kind of, I'll talk about these in a second, but it's kind of known as your upper strain. And with this one, it's made, they'll even tell you, it's made to be added to a coffee, tea, water, or juice. Okay, so again, these are the concepts of even the products we're seeing, right? And on a side note, another problem that we are running into is the product that could be loaded in here that people are actually using on our streets could also be laced with another product too. Okay, whether it's fentanyl, whether it's U4, what have you, there's so many different ones out there. N-bomb, there's so many different ones out there. But again, we're seeing laced and cut products also, meaning someone has added a drug to another drug. Okay, now right here, here's another drug enforcement officer. Okay, traffic officer, I mean, and here's what you have. All right, because awareness is going to be the first step. That's going to be a huge key, whether we're talking law enforcement or whether we are talking our community members. So right here, the officer talks about his awareness has increased 100-fold. Within 30 days, he located more THC and it not being in marijuana form. Because remember, we have to have a mind shift. That's a big reason we're all here today. We have to shift the way we're thinking and seeing things. Okay, the whole community does, right? And now when you get a mind shift, you start seeing things. From vapes to wax to candy, recently caramel-like substance being placed in the mouth, and as he says, the THC levels were off the charts, okay? Because again, how hard would it be to do this while driving versus to put a piece of candy in your mouth while driving? And do people view that as the same problem, right? Do they view, I just throw a piece of candy in my mouth, happens to have something on it, also now I'm driving impaired? I don't think that they have that mentality. I think some do, but I think some just look at it, it's just candy. I'm not smoking, I'm not doing all these other things, right? It's just candy. Okay, so we have to have a true understanding of what we're dealing with, right? Now, real quick, strains. As you guys know, marijuana strains have become very popular. Various different strains work differently. That's kind of an easy way to just throw it in a capsule for you there. So Kush is a really popular strain. Why I like to show you this one in particular, because it's one I see quite a bit. I see it on T-shirts. I see it on stickers. I see it in social media. I see Kush everywhere. Kush, this term pops up everywhere, okay? And Kush is a form of marijuana, okay? But this is what I want to get to, okay? So when we talk kind of our strains or strain classifications, you have a couple main ones that most of our marijuana falls under. Indica and sativas, okay? For some of you, this is the first you've ever heard of this, right? But yet, we've seen the signs and symptoms of it. So indicas, what users will tell you is indicas give them a body high. People will tell you indica means in the couch. You're couch locked. You don't want to get up. You want to veg out. You want to sit around all day. And then also, they'll tell you they use it because it gives them depressant-like effects. Okay, so indicas, when you walk into dispensaries, you'll actually generally see them labeled indica sativa. It'll actually be labeled almost like you're walking in to buy various different types of sodas and they're all labeled, okay? Now, here is the interesting one though. When I talk to people about sativas, you know what rolls off their tongue, and these are the users. You know what they say? It's your daytime strain. Okay, and that's what they call it. Sativas are known as the daytime strain, right? Because if I ask somebody, what's a sativa, they say it's a daytime strain. Let me ask you a question. What are most of us doing during the day? Okay, we're going to work, or even if you're youth, you're going to school, you're going to work. How do we get there? We drive. Okay, so think about that. If I'm referencing a drug as a daytime strain, am I saying it's a daytime strain but don't drive? Right? No, I've never had anyone ever say that to me. They just say it's your daytime strain. It's your get high during the day strain, okay? Which also means they're driving on it, which also means it's no big deal in their mind, right? Because it's your daytime strain. Of course you are, okay? Now, with this also, I've had people even say it helps me increase my focus, right? That's another piece of feedback we get. Okay, is it helps me increase my focus. I lock in better, i.e. I drive better, I work better, I work harder, I can focus more, I can study better. Okay, so again, when we start understanding what street level drug culture is telling our users, we're going to be better at what we do today. Okay, when you understand the mentality of what you're dealing with on the other side, you're going to be a lot better at your jobs, including myself. All of us are. Okay, but that's the big part, guys, is to understand it, right? Now, there's another one, hybrid, and a hybrid, to make a long story short, is a mix of multiple things, generally indicas and sativas and some other things. But what I wanted to show you was the bottom hybrid photo you're looking at. That's a photo from Craigslist. Okay, so that's online, right? That's just something, a website that many of us have used before, that you can go and find some of the drugs before. Okay, now, This was just about 3 weeks ago. That's why I like showing this one. So this email just came in about 3 weeks ago. She's a school nurse and she's an ER nurse, right? And this ties into what it says, what we just talked about, not making sense, okay? She talked about running into various different products, Xanax, marijuana, things like that. She says it was not making medical sense to her. People coming in showing various different signs and symptoms, but saying they were using this drug, and she's like, that just doesn't match up. Okay? Yeah, it does. When you start understanding the strains, the different products, the drug mixing, the poly drug use, the lacing, all these other things, it actually makes complete sense. Okay? Because this is what we're up against now. And also potency, forgot to mention that. The potency levels of the products too. Now, let me show you how the rabbit trail works. Okay? So I want you to take a step out of your world and step into their world for a second. So now you understand strains, and that's a really popular deal. So what pops up? A t-shirt that highlights strains. Right? But even better, in this t-shirt, here's what you have. You have a stash compartment in it. If you look in the bottom right of the corner of the t-shirt, I've highlighted it now in the photo on the left, that's a stash compartment. Okay? Now, how common have we run into stash compartments and simple t-shirts? Hasn't been super common, but it's changing now. It's becoming more common now, right? Why would I want to have a stash compartment in my t-shirt? Well, again, I'd want to have it because whatever is important to me, I'm going to need it that day. And that's what I'm putting in there. So it could be your house key, right? Could be your handcuff key, could be anything, whatever it is, okay? But understand whatever's important to you, because frequently that's what you hear. I'm going to hide my valuables. It's whatever's valuable to you. But in today, what we're talking about, what's valuable? The drug culture, okay? Now, and that's what the compartment looks like when you turn inside out under the shirt, okay? So, we've talked strains, so now you understand that. We're going to follow the rabbit trail again, right? This was in a shopping mall in the Midwest. So I walk into this store and I see Kush. I know Kush is a strain, so I see vape pens on it. Now, do I really think those vape pens are for nicotine? Okay? Because again, this is how the rabbit trail starts. Sometimes you wonder, how do people figure all this stuff out? It's actually quite easy if you look at it through their eyes. Okay, so now you see that those vape pens are going to be for marijuana and various forms of marijuana, right? Now, with vape pens, I'll tell you, there are no absolutes when you talk vape pens. Vape pens are difficult. Vape pens are almost impossible to identify what's in them, especially from a distance. Okay, you have to really be holding it, testing it, something. Vape pens really benefit the user. And that's fine when it's nicotine, but when it's not nicotine, it still really benefits the user. Okay? So now, with vape pens, when you look at this one here, just to kind of give you a little snapshot, in the box on the right, in the red, that box would generally be used for nicotine. But let me float a question out to you. If I were to add a little bit of LSD or some other synthetic in there, would you guys know? Okay, everybody would just know that I'm smoking something, but I have news for you. You already know I'm smoking something because you would see me holding the pen. So you didn't really figure out anything, right? All we figured out was, hey, there's an oil in there. But what is the oil now? Okay, so you could add just about anything in there, and now it's very easy to use and quite mobile. And that's what I explain to my classes. Why are vape pens, when you talk various drugs, so popular? They're discreet and they're mobile. Okay, I can move with these things, I can move quickly with these things, I can use them very discreetly. Frequently I will talk to clerks about vape pens and they will say it fits right in your hand and it's hard to see. Well, why are they telling me that? Okay, if I'm using a nicotine substance, why do I care that you guys see it? Okay, so understand that mentality, right? Now, the other vape pen types are sold and marketed. We see some that are sold and marketed for loose leaf marijuana. You can use loose leaf marijuana out of vapes. Also marijuana waxes that I just showed you in some of the various forms. We've seen people put powders in vapes. We have people who are using glycerin to break down other types of synthetics in vapes. I mean, it runs the gamut. It really does. Okay, so we see all different things in vapes. What I explain to people is there a heroin vape pen that exists? There is not. There's not a pen that's marketed and sold for heroin. Can you make heroin work in some vapes? You can, quite well. Okay, so again, it all is really specific on the user, which is what makes it very, very difficult. This is a photo I took on the West Coast. What you're looking at in his right hand is a little panda bear. That's the mouthpiece. What you're looking at in his left hand, that's actually marijuana waxes on the coils there. So what will happen is when he puts that mouthpiece on, you're not going to see anything now. All you would see in his hand is a vape, and that's it. Now, depending on your proximity to him, you might smell a little bit of marijuana, but it all just depends. Okay, and the other kicker is it's not going to be a lingering odor. So if this individual got stopped 20 minutes after smoking in the car, you're probably not going to smell a thing. Okay, so that's the difficulties now when we talk about the users, and the users know this and understand it. Now you can go to websites that you and I go to find various different vapes. So this one right here, it says disposable wax dryable vape. But here's where it gets really good. I'm going to underline this. I want you to look at this right here, okay? Ideal for on-the-go smokers or short trips away from home. Is that saying, hey, go ride your skateboard or bike or walk? Is that what that's saying? Okay? Absolutely not, right? What's that saying? You can toke up pretty quickly when you jump in your car. It's got to run to the store real quick. Right? Because again, what's the mentality? I'm not driving impaired. What those people talk about. I'm just, just taking a quick toke. No big deal, right? Again, that's the mentality we're up against, guys. And you even see it in the marketing tactics. Okay. Now, as I mentioned earlier, we're seeing everything in vapes. Just a quick snapshot on that. We are coming across every various different drug in vapes. Okay. Now, as my time is kind of coming to an end here, just the last few minutes to wrap some of these things up that I talked to you about. Like I said, we could have stayed here for a couple days, right? Understand what my goal was to kind of show you how all of these things are associated. What I call that big bowl of drug spaghetti, how everything is intertwined. You can't just separate it out. It is all associated, okay? And we have to understand the mentality of the people that we are working with and trying to help and trying to prevent and trying to stop this problem, right? The towards zero deaths problem that we continue to always talk about. So this issue is not random. The products are not random. How our people figure it out is not random. What they're doing is not random. I tell people the drug culture we're dealing with, the impaired driving culture we're dealing with is very organized and very calculated. It is not random. It is not just people going, I think this might work. They understand it, and we need to understand it as well as they do. Now, sometimes some of us can think we do understand it, and we don't. Okay, but understand now we take the next step forward and we take a step back and say, you know what, I don't understand this, but I'm going to make an effort to better get it. Now, we will always, in kind of our knowledge versus their knowledge, be slightly behind, but our goal is to not be this far behind, it's to be that far behind. Okay, so with that being said, stay active, stay informed, which it's all starting here. Many of us, I'm sure every state is represented in this room. You're going to go back to your states, okay? Don't go back and say, this was a nice meeting. It was a good meeting, great kickoff. Now, what do we have to take care of here? Go back and share the information, develop a plan, and start the conversation about what we need to do, what we need to get rocking and rolling back in our home states, because we're all depending on you, okay? Now, some of the things you can do for yourself, look past the obvious. Know that things are always evolving, okay? I explain to people now, when I left law enforcement at the end of 2015, because I trained, because of my passion for training, this is all I do full time. This is all I do. I'm in 2 to 3 states a week. This is all I do, okay, is train, train, train. With that being said, it's hard to keep up with. Okay, it's hard to keep up with trends and how quickly they change. And I don't have to go answer patrol calls. I don't have to go handle just wrecks that were non-impaired driving. I don't have to go handle domestics. I don't have to go handle all missing children, all that stuff. I don't have to go do any of that. I just do drug trends, and it's hard to keep up with. Okay, so understanding, guys, that's how fast it moves. Right? Just keep in mind, that's how fast it moves. And that's the true understanding we have to have. The things we're talking about today, there's going to be new things in 6 months. There's going to be new things next year. I explain to people that new things come out. Every spring is when I find a whole bunch of new drug clothing items. Okay, which is really in about the next month. I'll start finding them in retail stores, which means you're going to start seeing them on the streets, okay, here in the next 30 days, all right? Now, here's my contact info. On my website, Tall Cop Says Stop, you can email me through my website. So if you want to send me an email, and I have my email address up here on some business cards up front, so you can get a hold of me. I will be here till about 1 o'clock today, and then I have to fly to New York and do a training in New York. So you can get a hold of me today, though, or later if you have any questions or anything like that. I do appreciate you guys having me. I do appreciate everyone who's invited me up here and gave me some time to talk to you guys and talk to our beautiful country. So thank you guys for having me. Appreciate it. Thank you.
You have our commitment to be part of your journey. You have our help. That was, I'll tell you, I know it's hard to hear how much work we have ahead of us, but that's why we are here. We're here to help Officer Galloway, help each of you who are on a similar journey by coming together and sharing not only awareness of the problem, but best practices. Today, we will learn from panelists in the next 2 panels, providing an overview of what the science tells us and what challenges still face us in the science. We will hear about the strides being made in the communication of drug-impaired driving risks, the tools for identifying, assessing, and prosecuting drug-impaired driving. But we're also going to hear from each of you. You've noticed in the chairs when you came in that there are some Post-its in your chairs. I would like you to start keeping notes, writing down what you think we need to be doing. I need to learn, we all need to learn from each of you. If you think you don't have experience and expertise, surprise, you do. We haven't solved the problem yet. We don't know entirely how to do it. Your creative idea, whether coming from years and decades of deep expertise or whether coming from knowing people or hearing stories on the streets or just you have an idea, we need those. I want you to please write down your ideas. I want you to share those ideas on the boards at the side of the room. We've carved out some time after the panelists where you can speak with one another, argue with one another, but think of this as a brainstorming exercise. No idea is a bad idea at this stage. There's 7 categories on the boards. Looking around the room, I see communications, health and medical, law enforcement, miscellaneous, because if you're like me, you're going to come up with some random things. I'm sure you will. Prosecution, science, state law. I know there are other categories. The idea here is that we capture the ideas because the goal for this summit is not to talk and learn and scratch our heads and say, wow, this is really a drag. We want to leave here today having made progress. This is a call to action, and each of us are taking action. We're collecting our ideas today. The information generated will allow us to expand and work together. We're going to collect those ideas and start working on them here at NHTSA and with you. I'll have more information about that after the panels, but first let's go to the panels. Dr. John Kramer is the director of NHTSA's Office of Emergency Management Services. It's a great honor to work with him, and I'm thrilled to death to introduce him to lead our first panel. Will you please? Thank you.
Thank you. Good morning. Okay, you're not an EMS group. Come on. Good morning. Thank you. All right. It's my pleasure to be with you this morning and to introduce our first panel. By way of background, I'm an emergency physician and an EMS physician. I've been doing EMS for over 40 years. Before coming to Washington, I practiced in a level 1 trauma center for 20 plus years, typically being on the side of post-event activities and being faced with caring for individuals who were impaired and injured, or very commonly individuals who were secondarily injured because of impaired drivers. And if we get a chance later, I'll tell you about my September 11th story, which is not the same as your September 11th story. I'm looking forward to the discussion not only of our panel, but also the discussion of the rest of the day, and looking at it from the perspective of how we then take this message to the EMS community and have the EMS community part of working with you to address the problem. Our first panel is going to look at various issues helping to define the scope of the problem, and then we'll move forward onto what we can do. The second panel will talk about things we can do to start addressing those. It's my pleasure to introduce the panelists, and if you'll indulge me, I'm going to introduce all of the panelists at the same time so that we don't interrupt the flow of the discussions going from one panelist to another. Dr. Jim Hedlund is a principal with the Highway Safety North organization in Ithaca, New York, from which he consults on behavioral traffic safety research, policy, and management. He spent 22 years at the National Highway Traffic Safety Administration, retiring as the Associate Administrator for Traffic Safety Programs. Mr. John Lee Anderley is a retired lieutenant with the Laramie Police Department, where he served from 1993 to 2013. After retiring from the Laramie Police Department, he served as an impaired driving program manager for the Wyoming Department of Transportation Highway Safety Office until 2017, and continues to maintain certification as a drug recognition expert. Dr. Robert DuPont, for over 40 years, has been a leader in drug abuse prevention and treatment. He was the first director of the National Institute of Drug Abuse in the 1970s and the second White House drug chief. In 1978, he became the founding president of the Institution for Behavior and Health, a nonprofit research and policy organization that identifies and promotes powerful ideas to reduce drug abuse and addiction. Dr. Henlon.
Thanks very much, John. My assignment is here to tell you the data, what we know about drugs and driving, and I will concentrate on marijuana and opioids, key gaps in research and key gaps in programs, and I'm to do this in 7 minutes, all right? So I will do my best, and we'll try to talk fast. That's my job, okay? Much of this comes from a report that I wrote last year for the Governor's Highway Safety Association, Drug Impaired Driving, and I will put in a plug. There is a sequel to this coming out this spring, both funded by my friends at the foundation down here. So, I have about 7 things to say. Each will take about 1 minute. Here's the first. Americans use lots of drugs. Okay, you know the laws about marijuana, that it's now legal in 9 states in D.C. and medical in 29 states in D.C. Estimates of users are all over the place. This is a very conservative estimate of 22 million. Opioids come in 2 flavors, both the prescriptions and the illegals, and of course the prescriptions can be used illegally as well. About 250 million prescriptions written last year, something like 11 million people misusing prescriptions, and the number I saw the other day that really scares me, 116 opioid overdose deaths every day. For you folks in NHTSA, that's more than traffic deaths every day. But those aren't the only drugs. They're stimulants, they're depressants, they're hallucinogens, they're anesthetics, and you see some of the names that you recognize associated with those. Okay, drivers use drugs also. I'll give you data from 2 sources. The first is from NHTSA's Fatality Analysis Reporting System, or FARS. In 2016, the last year for which data are available, preliminary data to be sure, 44% of the dead drivers had at least 1 drug on board. Dead drivers with known test results, mind you. Marijuana was the most frequent of those, with more than 1/3 of those drug drivers having some marijuana around. Many of them had more than 1 drug. 38% of the drivers with known test results were alcohol positive. Think about that. Big qualifier. The FARS drug data are not good. State testing rates vary from 90% to 2%. Different states test for different drugs. They use different cutoffs. It's very difficult to make comparisons. So this is just an indication that there are lots of drugs out there in drivers who died in fatal crashes. This is not to say you should take that 44% number and run with it, okay? NHTSA's roadside survey that you heard Dr. Zobek refer to previously, this is the 2013-14 survey, 22% of drivers drug positive, both weekend nights and weekday days. It's not just a Friday, Saturday night problem. And again, marijuana is the most frequent. Again, drugs were found much more frequently than alcohol. Okay, there's drugs out there. Drugs can impair. Lots of experimental studies, particularly for marijuana. It impairs attention, it impairs your time and distance perception, your reaction time. No question there. Opioids can impair. Why do you take drugs anyway? Because they affect your body. Is it a surprise that, yes, you take drugs and it can impair your body in various ways? Stimulants stimulate, depressants depress, hallucinogens make you hallucinate. Surprise. Drugs can impair. Drugs can increase crash risk, and now here's where we start getting difficult. We definitely know some crashes are caused by marijuana and opioids. You just heard in the last speaker one crash at 9 o'clock in the morning caused by a different drug. Lots of studies on marijuana crash risk, lots of bad studies on marijuana crash risk. There is no real consensus of what the crash risk is with marijuana. Best guess is it's maybe someplace between 25 and 30%, but there are estimates from 0, it doesn't affect at all, to it affects by doubles or even more. And another point about marijuana and individuals, it affects different individuals in different ways. If you are a heavy marijuana user, tolerant, small amount may not bother you much. Opioids, there are fewer studies, similar flaws. Consensus is it probably increases crash risk somewhat. Notice all the qualifiers in that statement. I am not going to put a number on this, and nobody really can. State drug driving laws, they're very inconsistent. They're all over the maps. It is illegal in any state to drive while impaired by anything, any drug. That's the case. For marijuana, you've got 12 states with zero tolerance laws that says it's illegal to drive with any trace of marijuana in your system, and that can be not only THC, that's the active impairing component of marijuana, but some states have zero tolerance for metabolites, which can hang around your system for a week or two after you're smoking or vaping or whatever, long since after any impairment has disappeared. 6 states have set per se limits, but without any strict scientific basis of saying this much THC in your system will cause impairment. 19 states have zero tolerance laws for some opioids, typically the illegal ones, and a couple states have per se laws. Big takeaway here, your customary framework for alcohol does not apply to drugs. Alcohol is simple. Alcohol in your breath or body, and your body or breath equals alcohol in your brain, equals impairment, equals crash risk, and that's why we can set per se limits like 0.08 or in Utah 0.05, and they make sense. The BAC declines quite gradually after drinking. I can measure it an hour or two later. I can have a very good idea of what your BAC was when you crashed. Impairment signs are familiar. We know what drunks look like. Law enforcement knows very well how to detect them, and there's good roadside field sobriety tests. None of that applies to drugs. None of that. Drug in your body does not equal drug in your brain, does not equal impairment, does not equal crash risk. I can't make that connection. THC declines very rapidly after smoking, but impairment from marijuana can last for several hours. So again, the measurement doesn't correlate with the impairment. And of course, different drugs produce different signs of impairment, and you need blood or urine tests to confirm. That means you have to go back to the station, you have to draw blood or urine, you have to send it to a lab, you have to pay them a couple $100, and you get results back in 6 months. Very simple. So you can't apply the alcohol framework to drugs. Nope, back up. This is what I want to leave you with of what are the gaps and what could we potentially do about them. Number one, get better data. I'll say it again, get better data. with the inconsistent testing rates, the fact that a lot of drivers are not tested for drugs. If law enforcement finds alcohol, they will forget about the drugs typically. Get better crash rate estimates for marijuana and opioids. I told you how squirrely they are at the moment. We really need better ones. Get quick, cheap ways to detect drug use at the roadside, equivalent to the standard field sobriety test or the passive alcohol sensor. There's a lot of work being done on oral fluid testing that'll scan for a variety of drugs. There's work being done on breath tests for marijuana. Push those. And a better process to measure the drugs in drivers. It should not have to depend on taking a blood test, on sending it away, on waiting that whole time. Expensive, very inconsistent. What can we do? I give you 5 things. Educate the public about the impairing risks of drugs of all sorts. Train law enforcement. You've heard about A-RIDE and DEC previously. Those are vital for detecting and enforcing drug-impaired driving laws. Train prosecutors and judges. They are less well-trained than law enforcement. They often do not understand impairment by drugs. They don't understand the laws. They don't understand the signs and symptoms. They need training. Get standard drug test protocols across states so that when a state tells you something, it's consistent with what another state tells you. Some states even have different protocols with different laboratories within the same state. And finally, encourage drug screening and treatment for folks arrested of driving while impaired by drugs. Driving while impaired by drugs may not be symptomatic of a driving problem. It may be symptomatic of a drug problem, an addiction, something that needs to be dealt with on a much different scale from just passing a drunk driving law. I leave you with the following thought. Drugs, impaired driving, is a new twist on an old problem, impaired driving. The strategies are the same. Educate the public, pass good laws, use deterrence through laws, detection, evidence, prosecution, and so forth. It's the same problem, it's the same strategies, it's new twists, it's new tactics, it's new tools. So what we should do is implement and research these new tactics and new tools and build them into the impaired driving framework we already have. It's the same problem. We want to keep impaired drivers off our roads. Thanks very much.
We will have time for questions at the end of the 3 presentations, so please hold on to those.
Wait just for a moment for my presentation to be queued up. We hear the term preaching to the choir, and I see a lot of very familiar faces in the crowd, so it's nice to be able to connect with some of those people who I've gotten to know over the course of my career, and to be able to meet a lot of new people who share the same passion for trying to combat this issue. As you heard before, my name is John Anderley, and when I saw the 2 panelists that I was paired up against, I felt a little overwhelmed because these really are a couple of heavy hitters that have a lot more experience in some of the behavioral aspects and some of the psychological aspects to the issue. I want to talk to you a little more from the 50,000-foot view, the law enforcement side, the data side. So I want to talk generally about some of the types of drug-impaired driving. And as a drug recognition expert, we obviously have to be able to recognize the signs and symptoms in the 7 different drug categories. But primarily what you're seeing in the press and really in the national conversation, I can classify the types of drug-impaired driving into 4 general categories. We've seen a lot about marijuana legalization. We know that a lot of states have legalized both medical marijuana and recreational marijuana. One of the other challenges is in those border states who connect with a state where legalization has occurred. I come from Wyoming. I'll give Wyoming as an example where we're essentially surrounded by states that have enacted different forms of legalization and have caused issues on our roadways. One of the challenges with marijuana impaired driving, as you've heard from other speakers, is that there's a perception out there that marijuana actually makes me focus more, that I'm actually a better driver with marijuana, and it's way better than alcohol. So those are some of the challenges that we have to deal with from the prevention side of things. Just by a show of hands, how many of you have seen the news reports where police departments are now starting to put out photos of drivers that they found overdosed behind the wheel? Okay, I see a lot of hands up. I know one of the, I didn't use this one because it was so disturbing, but one that tugged at my heartstrings where parents were overdosed in the front seat of the vehicle with a small child strapped in the car seat in the back. You heard one speaker talk about the number of opiate deaths that we have every day. I believe the 2016 data suggests that over 40,000 people died of opiate overdoses in 2016. A lot of those people were behind the wheel. So these are the same people that are out on the highways and our roadways with you and I and our families. So it's definitely a crossover problem that we deal with the opioid overdoses. Talk about some of the traditional drugs. You heard Officer Galloway talk about his son who was hit by a methamphetamine impaired driver. And those people are still behind the wheel, the people that are snorting cocaine, the people shooting methamphetamine, the people shooting heroin. Some of those traditional illegal drugs that we can all agree are bad to put in your system, and even worse when you get behind the wheel and put everyone else in danger. And then another area that is a little more difficult to talk about is prescription drug driving. The last report that I saw suggested over 4 billion prescriptions were issued to American citizens. And it tends to, as we get older, you get more prescriptions issued to you. Some of the prescriptions are for blood pressure medication, which typically don't impair you, but others are for painkillers, for sleep aids. Ambien is a perfect example of one of those sleep aids, Zolpidem, where we don't think that anyone would actually take one and then get behind the wheel, but we consistently see reports of people who do just that. They want to be able to go to sleep when they get home, so they take the medicine before they even get behind the wheel, and then something happens on the way to where they're going. I can tell you about just in my little town in Wyoming where we've had several Ambien-related crashes. So people driving under the influence of prescription drugs are also a piece of this puzzle. And out of another show of hands, for those of you who are willing to share, the last time that you were given a prescription, how many of you actually read the pages and pages of warnings that come with that prescription before you actually use that medication? Not nearly as many hands went up on that question. So that's something that we all share a part in. So having said that, let's talk about changing perceptions. From my career in law enforcement to working with prevention framework communities around the state and working within prevention in my own community, I really think that it comes down to changing perceptions in 4 distinct areas. One is that we have to change that perception that you're even going to get stopped by law enforcement if you're driving impaired. When we look at the number of people who admit to driving impaired by both alcohol and drugs, compared to the number of arrests that are reported to the Federal Bureau of Investigation, it's an alarming difference. I won't talk specific numbers because we don't really know the true numbers. We haven't had a decent data report in about 40 years on the number of occurrences of impaired driving compared to the number of arrests. But we have to change that perception, and we're talking about a time in law enforcement where a lot of agencies are short-staffed. We have budgets that are being cut around the country. We have training budgets to be able to even train those officers. And when we look at some of the crime rates, especially in some of the cities where they have problems with assaults and homicides and some of those Part 1 offenses, it's difficult to assign someone to even work traffic. Traffic is the furthest from their mind. So that's one challenge that we have with law enforcement, is to get our chiefs and our sheriffs and our administrators engaged again in that idea that traffic enforcement works to reduce crime in other areas. Well, once that traffic stop is made, we have to change that perception that they're going to get arrested. Just because law enforcement comes in contact with an impaired driver doesn't mean that that impaired driver is going to jail. I'm guilty of it. In the 90s, when I started my law enforcement career, I lost track of the number of drivers who I felt were borderline. I thought, well, they're not falling down drunk, so I'm not going to take them to jail, but I'm not going to let them drive either. I wish I had some of those moments back, because I let a lot of impaired people go on their way, and a lot of them were contacted maybe later that night, maybe later that week, maybe during a crash that had I made the arrest, I could have prevented, because we were able to get them some treatment and get them some help. I know I see a lot of nods from some of my law enforcement colleagues in the room that they've been in that same area. So the training to be able to get these officers to not only make the traffic stop, but to recognize that impairment and to make the arrest based on that impairment is going to be critical. The perception that even if you do get arrested, that you're actually going to have your case taken to trial. I'd like to be able to tell you how many drug-impaired driving cases are taken to trial, but I don't know. That's one of the holes that we have in the data. We have no idea how many cases are actually being charged, how many are taken to trial. On the flip side of that, how many are adjudicated? And that goes hand in hand with that perception that even if you get convicted at trial of the offense, that there's going to be some meaningful consequences. We have a lot of great programs for alcohol-impaired DUIs. Within the drug-impaired world, we have drug courts, but drug-impaired DUIs aren't necessarily good candidates for a drug court. We have an increasing number of DWI courts, but not nearly enough to encounter the problem that we have. So that creates a perfect storm that affects some of these perceptions of what's actually going to happen. You're going to hear a very well-respected DRE in our community this afternoon, Chief Bob Tyser, talk about the DRE program. And I don't want to rain on his parade too much, but one of the tenets of the program is that we have 3 pillars that includes the police officer, the prosecutor, and the toxicologist. I think that's important. Those are 3 very important pillars of the program. But is that really all that we have? Okay, all of these programs have to be built on a foundation of data. We have to know what questions to ask before we know what questions need to be answered. And as you've heard almost every speaker talk about so far, data is probably our biggest missing gap in the pillars of the program. We really need to be able to drill down into what data we have, to be able to bring out some consistent data. We have a lot of differing state reports. One that really struck out to me was a NHTSA report on what's going on with drug-impaired driving in the states based on 2009 data. I can tell you in one state, not a single person who was involved in a fatal crash that was tested positive for drugs in this one state. Not a single person. There was another state where 77% of the people involved in fatal crashes tested positive for drugs. Well, I'm sure you're wanting to know which state 0 went in, because everyone wants to move there, right? Well, it might surprise you to learn that not a single person tested was actually tested for drugs. I mean, it costs money, as you've heard before, to be able to do drug testing. In some of the states, we do a really good job of getting the coroners involved, especially in those fatal crashes, on being able to get samples from those drug-involved drivers. It's not that way in all the states. And even with that, we have other issues. When we talk about alcohol, our reports are alcohol-impaired driving. When we talk about drugs, we talk about drug-involved driving. 2 very different words with 2 very different meanings. I think we can all in this room agree that at a 0.08 or greater, you are impaired by alcohol. We don't have that consistent level with drugs. And Dr. Hedlund had one quote that I had to write down because I thought it was so salient to this conversation. I'm not putting a number on this, and no one really can. That's why that training piece is so important for our law enforcement, to be able to recognize that impairment roadside. And then we can use that testimony about impairment compared with a number and help our prosecutors and help our juries make better decisions. Okay. Cutoff levels is another contentious point. I think if you were to get data from the 50 states that do drug testing, you're not going to find very consistent levels of cutoffs for their actual testing. I know in at least one state that is really working on this issue, they were using the cutoff levels for drug-free workplace testing, which are significantly higher than those recommended by the Society of Forensic Toxicologists for forensic testing of drug samples. It would be nice to be able to see us all get on the same page on at least what kind of samples we should be testing and what kind of cutoff levels we should be testing within those samples. From one state to the other, you're going to find different answers. Okay. We have other testing limitations. There's a lot of states that because their backlog is so long, it can take up to 18 months to get a result back after an arrest. Now, what kind of criminal justice purpose does that serve when we let this person, who we need to get help, lounge around for 18 months waiting for some type of answer on what we're going to do with this case? In other cases, if a person comes in and pleads guilty the next day after the arrest, that sample will not get tested. They're so busy doing other tests, you're not actually going to find confirmation. And that certainly affects the data that we have. Another issue with the limitations is when we talk about polycategory use. And we haven't touched on that a whole lot, but when you're using more than one substance, if you're mixing alcohol and marijuana, if you're mixing heroin and cocaine, one of the big problems that we have within the drug testing community is if that alcohol level is at a certain amount, the lab won't even test for drugs after that because you can make your case based on the alcohol. So those are all challenges that create that perfect storm. The adjudication side of things, we talked about that. We have no idea nationwide how many cases are going to court. Out of those cases that are going to trial, we have no idea how many of those are ending up in guilty pleas, in jury trial findings. And very closely connected to that is the idea of probation. We have some pretty good plans in place for dealing with alcohol-impaired drivers. How many of you have heard of the 24/7 program? Okay, very robust program. Nothing like it exists for drug impairment. So when we deal with a lot of these issues, we have to determine how to move forward. And certainly my opinion from the enforcement side of the perspective is to expand our training programs. We have a lot of very highly qualified, highly trained drug recognition experts around the state, but I'm hesitant to say that we need to add X number of DREs to the mix, because there's a lot of support that we have to build for the program. That starts with the lower levels of training. The SFST, the standardized field sobriety testing training that police officers generally receive at the academy level, although a lot of police departments don't require that base level field sobriety testing training even at the academies. You've heard a couple of speakers talk about the ARIDE, Advanced Roadside Impaired Driving Enforcement. Fantastic program. It builds that bridge between that initial training on how to detect alcohol impaired drivers with the advanced training that you get for the drug evaluation and classification program. But we need to get that expanded out. Prosecutor training. The National Traffic Law Center, I saw my colleague Tom Kimball in the room. They've developed a great program called Prosecuting the Drug Impaired Driver. The problem is that generally the newest person in the prosecutor office is the one that gets stuck with doing these cases. I mean, I've talked to a lot of prosecutors who would much rather prosecute a homicide because typically the jurors sitting in that jury box haven't killed another person. But when it comes prosecuting a drug-impaired driving case, maybe a lot of the jurors have been in that position and are looking at that defendant saying, "There before the grace of God go I." It's a much more difficult case with a lot of different types of testimony to work through. Talked about some of the limitations with toxicology testing. Not only does equipment need to be replaced ever so often, and I just heard a great update from Wyoming where we've had some challenges with toxicology testing, that our Division of Criminal Investigation is going to use drug forfeiture funding to purchase new equipment to be able to do toxicology testing. Talk about making the bad guy pay for the cost of drug-impaired driving testing. I think it's a great idea. And then we talk about strong state coordinators. Each state and commonwealth has a state coordinator coordinating the drug evaluation classification program. That's not the same with other impaired driving programs. Not every state has an SFST coordinator, but those people need to work together, and we need to have strong state coordinators that know the program, that are not just administrators, but can actually get down to the ground level and be able to work with what needs to be done within the programs. Need engaged state highway safety offices. Everybody's busy. Everybody has other problems that we deal with highway safety issues. But to bring those highway safety offices, and I think the opportunities, I see another colleague with the GHSA, to be able to get highway safety offices engaged in some of the solutions to this is critical. And then also talk about getting informed partners. And this is not only at the federal level, because these impaired driving issues cross over to the Federal Motor Carrier Administration, to the Federal Railroad Administration, the Federal Aviation Administration. We have impaired operators in a lot of different modes of transportation, and getting some of those federal partners engaged in this issue, along with those state partners, not only the state highway safety offices, but almost every state has some type of grassroots organization that deals with advising the governor or advising other areas of government on the issues. And we need to be able to get on the same page with what our expectations are and what some of the solutions are. And then finally, those local areas. There's a lot of chiefs and sheriffs around this country that don't believe in DRE. I know that's not a popular thing to say, but I see a lot of nods already because some of you have dealt with some of those chiefs and sheriffs. Say, my guys have more important things to do than go chase drunks and drug drivers. Like, well, I think back to my career where I've made several hundred DUI arrests, which for my little town wasn't bad, and in the whole scheme of things, they're not great numbers. Some of them were more memorable than others, but what I can tell you is the 4 times in my career that I had to knock on a door and tell a parent that they had outlived their child because of one of these cases. And for me, from my experience, there was no tougher call in law enforcement. And that's what brings me here. That's why I'm here. I suspect that's why a lot of you are here. So all of these things are needed to really bring a holistic approach to have a robust and successful program in really reducing those impaired driving numbers. And that is all I have for you. So I'll turn it over to our other heavy hitter.
Thank you very much. It's a privilege for me to be here. I am thrilled to be with you, and I want to use the word historic. This meeting is historic. This is really, really important, what we're doing here. We're not just here to talk to each other. We're talking about a level of commitment to deal with a problem that is urgent in our country. And we've got leadership now in the Department of Transportation, in Heidi King, that is going to make a difference because she explained how she got to that. And that is really important. And NHTSA has got capabilities. Jeff Michael is one of the great public servants I've ever worked with. And he has a wonderful staff. And so what we're doing here is really important for the whole country as we organize and to deal with the problem. Now, I want to back up and just say a couple of words about me, my background. July 1st of this year marks 50 years since I started in dealing with the drug problem. I got my first job after my training. I was trained at Harvard Medical School, NIH, and I wanted to do something that would be helpful because my heroes were John Kennedy and Martin Luther King Jr. And I wanted to work in corrections because I had been fascinated by the people who were in prison, and I wanted to help them. So I went into the criminal justice system and discovered the drug problem in that context. And that's all my career then flowed from those early decisions. You heard that I was the first director of the National Institute on Drug Abuse. I'm very proud of that. The second research monograph published in 1974 by NIDA was about drugged driving. We have had decades of research on this. I go crazy when people tell me we've got to have more research before we act. And that's not even close. Now, before I get into more of these things, I just want to mention one other thing, and that is, in this audience, there's one person in particular I want to make sure you all see and get to know, and that is Mr. Ed Wood. And I would like to have him stand up, tell you a little bit about this gentleman. He has devoted himself to the issue of drug driving. Here he is, my hero, because his son Brian was killed by a drug driver, and he has devoted himself for 7 years. He is the expert, because he, unlike me, has spent full time on this issue. And he now finds himself in Colorado, which is ground zero to the problem. Now I want to step back with you and say why we are dealing with this problem. What is behind this? What makes this happen to us? We are in the midst of a massive drug abuse epidemic. We're talking about the aspect of that epidemic that has to do with highway safety. But the underlying problem is the drug epidemic. And it's historic. Talk about some numbers. In the United States, the leading cause of death for Americans under 50 is now drug overdose. Think about that. That's unbelievable. Do you know that for the last 2 years, the life expectancy of Americans has gone down for the first time ever because of the drug problem? Think about that. The highway deaths are up for 2 years in a row. That never happened before. These are really important markers of something very important. We are also in the process of adding a third legal drug. We have tobacco, we have alcohol. We are hell-bent on making marijuana a legal drug in this country. The other two drugs are the leading causes of preventable death and injury in the country. We're adding a third. So this is historic. It's very important for the country to deal with this problem, and we're a part of that. And I want to say one other thing about why it's happening. Why is this occurring? People do not understand the power of the drug experience to change people's behavior. And you talk about why do people use drugs? All these different drugs we've talked about, they all have one effect, and that is brain reward. They literally hijack the brain's reward mechanism. It doesn't have to do with whether you're old or young. It doesn't have to do with you're black or white or red. It doesn't have to do with you're rich or poor. It's in the brain, that vulnerability. And you can see this with laboratory animals. They will work harder for the drugs than sex or food or anything else. That is biology. It's inescapable. And what's happened is, unlike before, we've got a massive capability, commercial capability, illegal, to provide drugs. And as you heard in the presentation, it's very creative how it's marketed, how many drugs it is. And right now, the illegal drug supply is delivering more products of more potency. They're all going up in potency. They're cheaper, and they're easier to get, more convenient. Think about what the consequences of that are. And we're focused on a part of it, but I want you to get a picture of what that context is. Also, the issue about drug users' motivations. Drug users' motivations are to use drugs. And you see this very clearly when you see that drug users pay $100 billion a year for illegal drugs in this country. The entire treatment system and everything we have is $34 billion. They pay cash for the drugs, could pay for all of it with 1/3. So keep in mind what's going on. It's a pretty difficult challenge for us. Now, I want to talk a couple of things that came up a moment ago about THC. I got a little crazy about this, about the metabolites that are in the urine or anywhere else, the blood. If there's a metabolite of THC in the urine or the blood, there's THC in the brain at that time. I don't care if it's 3 weeks later, because the THC stays in the body and the metabolite is quickly excreted, because the THC is sequestered. So when you hear somebody tell you it's only the metabolite that's there is THC in the brain if there is metabolite in the urine. It is that simple. Now, you can argue whether it's having any effect. That's a different issue. But it's in the brain at that time. The other thing was comment about 24/7. 24/7 is a wonderful program. I'm on their advisory board. They definitely test for drugs. It's very much, it works for both drugs and alcohol, and it's a wonderful program. Now, the alcohol model is great for us in terms of prioritizing. In terms of the message, don't drink and drive. You notice that motto is not don't drive drunk, right? The motto is don't drink and drive. That's really important to hear that. And we can do that same thing with drugs. Don't drug and drive. And that's useful. That's a good thing. The whole business of public education about alcohol and public education about drugs directly applicable. Where the problem comes is the BAC .08. And as you heard earlier, there's a simple reason for that. And that is alcohol is soluble in water as well as fat. And so it's the same throughout the body. THC and the drugs are not like that. They are kept in the body and not in there, so you don't get a equivalence in the urine or the blood that you do in the brain. That's one reason. But there's another reason that's really important also, and it's true for alcohol, but less so, and that is the effect of tolerance. People say, what is the level of a drug that is associated with impairment? And I have a simple example from my own experience. I do a lot with drug treatment, and methadone is a form of treatment for opiate addiction. A methadone dose, a person in a methadone program, about 100 milligrams a day is kind of a typical dose. You have much higher than that. That's a typical dose. What's the impairing blood level of that? Well, 40 milligrams of methadone is lethal to a non-tolerance person. How's that for impairment? Dead. And it's 2.5 times that with no impairment. Are you going to find a methadone level that correlates with impairment? It's not even close. You're not going to do that. More research will not help you solve that problem. And I go a little nuts again about people who want us to find that. We just need a little more research and we'll get that number. Come on. That's not even close. Now, and also I hear about data. We have a lot of data that drugs are a serious highway problem. Plenty of data. Any more data will just be icing on the cake. We don't need more data to know it's a serious problem on the highways right now. We can do the National Roadside Survey was the trigger to get the federal government interested in this. And it's a wonderful system, and it gives you strong evidence of the extent of the drug use and driving. The FARS data is strong evidence of the connection with drugs to fatal accidents also. And here's another thing that I think is really important for you to think about. when we talk about what happens at the highway setting where a determination is made of a problem, arrest is made. And there's this sort of an argument that the sort of innocent drug user is going to be endangered by the drug test. Remember this, before the first step is there's probable cause. The officer has some reason to believe there's a problem with that driver. And the second is an assessment of impairment. Only after those two things is the person drug tested. And that's very important to think about that when you talk about the consequences of it. The last thing I want to make about this, I think I want to say about the sort of bigger picture of this. There aren't very many people who use one drug. Marijuana in particular, but they're all like that. They're using many drugs at the same time. And it's very interesting. Why is that? Why do they use so many different drugs? And I have had frustration with my science colleagues because all the science and all the treatment is drug specific. You know, the diagnoses, opioid use disorder, alcohol use disorder, opioid overdose deaths in the front page of the paper. Do you know that 96% of the opioid deaths had other drugs present at death? 96%. The average was 2 to 4, and they had as many as 11. Why are they doing that? And the science is silent on that. I can't get the researchers interested in the question. But the answer is that drug users are doing research on brain biology to figure out how to get the maximum stimulation of brain reward. And their experience tells them that with multiple drugs does that better than one. They don't just raise the dose of one, they add other ones. And that's also about overdose deaths is because of the mixing of the drugs. And that's true on the highway. And we need to think not drug at a time, but think about combining the drugs and identifying that and seeing that as a particular concern. That's really important as we go forward with this. So I'm going to just end with some things that I'm interested in or promoting. But I want to emphasize that we're not talking about a final solution, an answer that covers everything. We're talking about incremental steps. We're talking about what can be done to improve what we're doing now about drug driving. I also want to remind you, I told you I got into this whole mess of my life about being concerned about people who are offenders. And one of the things people don't talk enough about is how the criminal justice system is an engine of recovery. How many people change their lives for the better because they get arrested. How often that happens. And a stunning example was a drug czar for President Obama, Michael Botticelli, got into recovery only when he was arrested for a serious DWI accident. He'd never been to a meeting in his life until then. And his life course changed, and he changed the world. But it all happened because he was arrested. And I think we need to think more about arrest as a positive thing and how to help people with arrest, as I say, as an engine of recovery. Okay, so here's the things. First of all, we need to focus on the dead drivers and get good data about them. That's really important to do that, to make that a commitment, to understand that. Because they have, what is that line from the medical examiner, that take the last testimony of this person that can help the living. And this is a way to do that. All drivers tested for impairment need to be tested for drugs as well as alcohol, to set that as a goal of what we want to do. Oral fluids testing is a step forward in many, many ways. I'm not going to go into all that, but it's good technology, it's good science, and it facilitates, it gets away from the bathroom problem or having to get a blood draw. And it's useful data. Is it perfect? No, but we're not dealing with perfection. We're dealing with a step forward, and that's a big step forward to do that. Here's a simple one. We have a standard for alcohol that under the age of 21, it's not BAC .08, it's any alcohol is a violation. That's because it's illegal to drink. Why don't we have zero tolerance under 21 for marijuana and other drugs? It seems to me, I don't know how anybody can be against that. It's illegal for the kids to use it, and that to me is an easy one. The use of administrative license revocation. So there's an immediate consequence for an arrest for DUI, I think is very important. And then, as I mentioned, a penalty, an additional penalty for multiple drug use, I think is very important. But I'm going to end by just saying how proud I am to be with you and what's happening here. And I see this as the beginning of something very important that we need to devote ourselves to. It is a matter of life or death, and we are dealing with a major aspect of a massive epidemic that is not an American problem. This is a global problem. No doubt about the brains of other people is the same, and the interest of the illegal drug market in their money is just as much as our money. So this is a global problem, but we've got a long way to go to solve that problem. This is our part we're focused on here, and thank you very much.
Thank you to all three of you. We do have a few minutes for questions, and I think Caroline will be running around with a microphone if we need it. I'm going to start out by doing a quick survey. How many of you here are still currently active in field law enforcement activities? Okay, we have several folks. How many of you are in the court or legal system? How many of you are involved in EMS? Field response, mental health and social work? Several. Okay. Other areas of the medical field, medical examiners, things along those lines? All right. How many are local policy or regulatory folks? How many at the state level? How many at the federal level? Okay, we've got all the groups except medical examiners. Interesting. Thank you. Questions or observations for any of our panelists? Please. Caroline's coming up with the microphone. Oh, can we have the portable mic up, please?
Hi.
Thank you.
First, what? Okay. So first I want to thank all of you who used the word crash in your presentations. I think it's really important that we emphasize that these are not accidents, that they're crashes. Let's not give drugged drivers an excuse to continue driving drug. Secondly, Jim, I loved everybody's presentation, but you said something, and I tried to write it down, and I didn't get it fast enough, that I think we overlook because we get so hung up on the science of this, and that is they take drugs for a reason. And I wish we could say that more instead of, well, science is important, but we could say that more and emphasize the common sense approach to this problem, which I don't think we do quite enough. And that is, you take drugs for a reason, to change how you feel or think or whatever, and obviously that's going to be somewhat impairing. So, do you agree?
I do.
Oh, thank you. Just wanted to hear it. Thank
I don't know
you.
if this works or not. I can speak loudly. That's a point that Dr. DuPont made, that often traffic stop is the way to identify somebody with a drug or alcohol problem, get them into an assessment, get them into a treatment, try to deal with their lives, not just their driving.
Question up here.
I want to follow that a second, Dr. Hedlund and Dr. DuPont. The traffic stop will get us, get that person identified, but the reality in our system of justice is until somebody gets convicted, they don't get into rehab. Until they get convicted, they don't get into the DUI court until they get convicted. So I think one of the points of emphasis, of course, maybe not being a prosecutor, I would say this, but somebody made the point that these cases tend to be assigned to the new prosecutor, the newest one on the block. I think that came from you, John. And that system doesn't mean that we have the best trained prosecutor handling these extremely serious cases. So I'd like somebody to address what do you think from your perspectives could be done to change that, other than more money?
That's not necessarily a problem with just the prosecutors. We also have an issue with our DREs, where we train a lot of DREs around the country every year, but we also lose a lot of those DREs because they get promotions to other positions. They have other roles that they need to take. I don't think that's any different in the prosecutor's office. I think that the key really is to have those DAs and the county attorneys and the chief prosecutors support their people. And instead of making it sound like a burden that, hey, you're the new guy, you get all the impaired driving cases, maybe spread the wealth a little bit. Because having a mentorship program where you have some of your more veteran prosecutors who have been around the block a few times, be joined by that new prosecutor, and let the new prosecutor know that no one's too good to take an impaired driving case. Having come from working with a lot of prosecutors, I think that would go a long way to have those bosses show that they're willing to do whatever they're asking everyone in their office to do.
Right behind you.
It's not necessarily true that you have to wait for a conviction. Connecticut has a very good program that starts ignition interlock after a third arrest for drunk driving using administrative license suspension, which was mentioned. There are programs in Pennsylvania, South Dakota, other places throughout the country where they start the 24/7 monitoring initially after arrest as a bail condition. My home jurisdiction of York County, Pennsylvania, 75% of our drunk drivers are in treatment before they plead guilty. So there are programs out there. Again, it comes back to education of prosecutors, judges, the criminal justice system in general. But there's a good push nationwide to get a risk and needs assessment done among individuals. Actually, in some jurisdictions, police officers on the street are doing it to determine whether even arrest has to be done, not just for DUIs, but all crimes. And really, that's where we got to move. Get that risk and needs assessment done early on, get the folks into the treatment that they need, be it substance abuse, mental health, whatever, as soon as possible.
Thank you. Other questions? Yes, right back here, Caroline. And I also know from being in your position, we want to be very sensitive to allowing for the breaks, so we'll break in just a second.
To Lieutenant Elderly's comment, I just wanted to say that if you're looking for a model prosecution program, Orange County, California is one, and Jennifer Harmon is here from the Crime Lab. You'll hear from her later, but it is a terrific mentoring, step down, everyone trained, committed, high testing, and a super win rate. So go California. And Chris Murphy is here. Yo.
Great. I want to thank the panelists. I want to thank all of you. A quick reminder, please make use of your yellow and blue sticky pads. And the yellow, I think, is ideas that you have for immediate action, something that we can do to save a life today. Blue references something that we should do over the next, 2 or 3 weeks. What's your timeline? Thank you. Thank you for the panelists. We'll reconvene at 11:15 for the next panel.
Folks, if you could please take your seats, we're getting ready for our next panel. We'll start at 11:15. If you could please take your seats, we'll get started with our next panel. Thank you.
If you could take your seat, we'll get started with our second panel. Thank you. Well, thank you very much. Good morning. My name is Jeff Michael. I'm Associate Administrator for Research and Program Development here at NHTSA, and thank you all for coming this morning. The last speaker on the previous panel, our favorite drug czar, Dr. Bob DuPont, made I think, an excellent transition between the two panels, and his closing message is my opening message, which is, while it's true that we have a lot yet to learn about drug driving, we know plenty, and there's lots that we can do now, and we have a panel of people who are doing it, and they're going to tell us about that. So a little more detail. So we've been working with alcohol-impaired driving for as long as Dr. DuPont has been involved in drug driving, which is 50 years or more. And we haven't solved that problem, but we've reduced it quite a lot. And we've done that by developing some methods from prevention to rehabilitation that are quite effective. And we've studied these methods for 50 years. We've refined these methods. Not all of them translate exactly from alcohol impairment to other drug impairment, but many of them do. And we have some people who are doing some excellent work with data system development, with law enforcement, with public education, and with rehabilitation, and we're going to hear from each of them. Like Dr. Kramer, I'm going to introduce them first, and then we'll have short presentations from each, and at the end we'll have some time for some good audience discussion, I think. So first, with regard to data system development, we have quite good data on alcohol-impaired driving crashes. It's not perfect. We even in last year in 2017, we only had data on alcohol for 70% of the fatally injured drivers. We didn't have 100%. And so it's good, but it's not perfect. We also have some pretty good data on drug driving, and our first panelist, Jennifer Harmon, is going to tell us what can be done with those data. Jennifer is Assistant Director of the Orange County, California Crime Laboratory, and she oversees the Forensic Chemistry Bureau. She is also president of the California Association of Toxicologists, and she's been working in this field for almost 20 years. And she's testified in front of the California legislature a number of times, and she's also provided expert testimony at least 200 times in administrative and criminal hearings. She's doing an excellent job with drug driving data collection from the crime lab, and she's got some interesting data to share with us. Certainly, law enforcement has been a cornerstone of our progress in alcohol-impaired driving, and Bob Tyser is with us from the state of Colorado, who's been in law enforcement for also almost 30 years. Bob is currently chief of police in Loveland, Colorado. Before that, he was chief in Avon, Colorado, and before that, he's spent 20 years as an officer in the Department of Public Safety in the state of Arizona. Importantly for this discussion, Chief Tyser is currently chair of the technical advisory panel at the International Association of Chiefs of Police, which is sort of the key position for our drug recognition expert program. So he is the guy to talk to about the DRE program. He's going to talk to us a little bit about the strengths of that program and how it's working for both alcohol and drug impairment. Certainly, public attitudes about alcohol-impaired driving have changed drastically over the past, certainly over the past 40 years. And while I think the cause of that change is probably a number of factors, including laws and law enforcement, it's clear that we wouldn't have those laws, we wouldn't have that kind of law enforcement if we didn't have good public awareness and public education about alcohol-impaired driving. The state of New Mexico has for years been very progressive, been a national leader in alcohol-impaired driving programs. They're now a leader in drug-impaired driving programs. Mr. Mike Sandoval has been a leader in that state since I've known him for probably the past 15 years. He is now division director for the Division of Motor Vehicles. He was previously division director for Division of Highway Safety. He's going to tell us about some of the work they've done both with alcohol-impaired public education and now drug-impaired public education. And finally, speaking for that extension of our criminal justice system, which seeks to rehabilitate offenders and prevent reoffenses, we have with us from West Virginia University, we have Frankie Tack, who is a assistant professor at WVU. She's a certified advanced alcohol and drug counselor and is currently the addiction coordinator in the counseling department at West Virginia University. She's going to talk to us about how rehabilitation works both with alcohol and with drugs, and the potential that function can serve in reducing the drug driving problem. So I'll introduce our first speaker, Jennifer Harmon. And if you save your questions until after all of the panelists, I think we'll have time for a good discussion.
Thank you. Good morning. It's a little early for me because I'm about 3 hours behind you. So my name is Jennifer Harmon. I'm an assistant director with the Orange County Crime Lab in California. We are the 6th largest county in the United States with a population of about 3.1 million folks. We do have an interesting dynamic in that as a county, we are located between San Diego and the border. and LA County, two larger counties on either side of us. And we have a very interesting dynamic and diverse population. We have a very affluent population. We have a large immigrant population. And we have a lot of folks who come to Orange County to go to the happiest place on earth and visit Mickey. So we have some interesting information when it comes to drugs. We've been studying driving under the influence of drugs. Really, we started about 15 years ago. We got going about 8 years ago in partnership with the Office of Traffic Safety. I'm going to go over some of our initiatives and some of the work that we've done in our county to try to help understand the problem and be able to participate with the criminal justice system in understanding what is really going on with some of these drivers. So the Orange County model is a three-part model. We have the district attorney's office, the crime lab, and then law enforcement. And what has worked so well for us in Orange County is that we have worked collaboratively as a group. We have had consistent leadership in all three of these entities, regardless of who has moved on or promoted. They have maintained a passion and a responsibility for dealing with traffic safety issues and trying to find a way to work collectively to deal with the problems that we each uniquely have. Law enforcement certainly are the first responders and are dealing with those folks who may be impaired. The crime lab is part of that process in that we are the ones who receive the evidence and then have to analyze that evidence and interpret that evidence for court. And then the prosecutors, of course, and the criminal justice system as a whole have to then take that information and work through an adjudication process. We have found that it works best in our county that all of us work together, that we train together, that we understand what each person's needs are and the limitations. As a crime lab, our responsibility is to advocate for evidence and to advocate for science. Our job is not to prosecute people. It is not to help somebody, either get a guilty or not guilty plea. That's not our responsibility. We're not here to advocate for that. We're here to advocate for the evidence and what the evidence says. But us having collaborative relationships with our law enforcement partners, with those in the criminal justice system, it does help everybody understand what the other is doing and what someone may be doing that is really counterproductive to the system as a whole. Something that has been spoken of today and is important to note, that a lot of our drug drivers, especially in our county, are being treated as alcohol-impaired drivers. And we understand that there is a significant difference, and so our goal has been to make sure that our system understands that there's a difference between drugs and alcohol. Alcohol is the most widely abused, but that folks using drugs may be treated differently and need to be treated differently. So we have three major initiatives that go on in our laboratory. We focus on three things: technology, research, training, and collaboration. Technology, what we have done is we have actively used grant monies as well as other sources. Asset forfeiture is one of those sources, and fees to determine proof of concept. So before we fund some sort of technology project in our laboratory, we have to demonstrate that it's going to work. One of the biggest challenges for crime labs right now is the resources that are needed to really test for these types of drugs. The equipment that's needed is hundreds of thousands of dollars. And so if we're going to expend that amount of money on technology, we need to make sure that it works. We also want to work smarter, not harder. Okay? In my laboratory alone, we have been able to go from testing 3 compounds, determining blood concentrations, to 72, and we've done that in 6 years. And we've done that through technology, and we've done it without having to add staffing resources. So technology is a tool that we can use to better address a lot of these problems, but we also need to make sure that it works. We use automated platforms that have dual purposes, robotics. We use liquid chromatographs. You'll hear, I'm sure some of you who are involved in this testing are aware of this. And we have new technology coming online, time-of-flight technology, that will allow us to actually identify hundreds of drugs from the very first test, which is really helpful for us. The other thing we do is we conduct research. And the reason we do that, we are a practical, applicable science in forensics. We have to be able to take information that is somewhat complex, we take theory, and we have to apply it to the field. And so in order to do that, we need to be able to answer the questions that we ourselves are going to be asked in court. And so what we've looked into is we do a lot of work on drug prevalence. What are we seeing in our populations? Our under the influence, our drug-facilitated sexual assault, our driving under the influence. And a unique perspective that Orange County has is that we also do work for coroner's office, so we have fatal data as well. We are able to marry fatal data, driving under the influence data, drug data, as well as possession data, because we also analyze the solid dose drug as well. We are doing a lot of work on drug stability, and the reason for that is the turnaround times in public crime labs are long. We need to know that if we're going to produce a number, that it's a reliable number. Are our collection methods sufficient in order to get results that are meaningful, that we are now going to then populate local, state, federal databases that could then be pulled upon in order to make policy? We also do quite a bit of work on and have actually published scientific literature on the effectiveness of DRE and SFST. Can you correlate a level of THC, the active component found in marijuana, to a level of impairment? Can you correlate a level of impairment to an actual blood concentration? And we've been working with other folks, including partners in the DRE program, to assess how useful those skills are. And I'm here to tell you that they are. Those tools, even though originally designed initially to validate for alcohol, the DRE program has been validated and used for drug impairment for a long time. And we have scientific proof that it's still meaningful, useful information. We also do a lot of work on training and collaboration with some non-traditional partners. We work with public health. We work with our preventative health partners to help them understand what sort of drug trends are coming or that we're seeing in order for them to better their education tools. We work directly with our DRE, ARIDE, and SFST statewide coordinators and local coordinators in order for them to have all the information they need in terms of a toxicology perspective to train their officers. We train toxicologists, and this is a really big deal, because in crime labs, toxicology is competing with resources for crime scene, for firearms analysis, for DNA. And so it is just one area that needs to be covered in that crime lab budget. And so a lot of the toxicologists don't necessarily have the training that they need in order to effectively go into court and articulate their findings. So we've been hosting workshops on how to develop meaningful methods to make things faster, to help them do a better job, get a more quality result, but also how to be expert witnesses for the court. So I'm going to talk a little bit about drug prevalence because I've heard the word data mentioned at least 10 times today. And so I'm going to get through that really quick. So some of the data that we have on our fatally injured drivers, we are showing that about 50% of our fatally injured drivers have at least one drug in their system. Year over year, we are studying baseline data to determine if at that baseline, and it looks like folks are having a hard time seeing it, I apologize for that, to see if, since California has legalized marijuana, are we seeing a change? Did we see a change in our fatally injured drivers from the point in which, prior to legislation, once legislation came into effect, and then once retail sales have come into effect? And I can tell you from the 2015, 16, 17 data, we have not seen a significant change. Now, retail sales went online in California in 2018, so we do think that there may be some delay in what we're seeing, although we don't necessarily expect our numbers to be that Colorado and Washington have seen. California has had marijuana laws in place since the 90s. One of the biggest, and I will echo the point of Dr. DuPont, that the fatally injured driver data is probably the most critical. It is not dependent upon folks who, whether there is enforcement available on collection or testing delays. We are really just dealing with those operators who have been in fatally injured crashes. The only problem with that data is that we only test about 80% of those cases. More than 20% of the cases don't come to crime labs for testing. We have seen a slight increase in our THC cases, but ethanol still is the most prevalent drug in our fatally injured drivers. THC would be second, and then next, which is not up there, is methamphetamine, closely followed by our benzodiazepines, which are prescription medications, things like Xanax and Valium. The data in our fatal drivers is very similar to our apprehended DUI drivers. I should note on the fatal drivers, this is not about causation. We have not done any study on that. This is just merely prevalence. On our arrested drivers, what we are seeing again is nearly a 50% rate of cases where individuals have tested positive for at least one drug. In August of 2017, Orange County took on an initiative to test all drivers regardless of their blood alcohol level. So the data that you have up here today is of that population between August and December of 2017 of all drivers that we're testing. So we are actually seeing almost a 20 to 25% rate of prevalence of THC in drivers. This is the active drug, okay? And I'm also here to tell you that nearly 35 to 40% of our above 08 drivers have at least one other drug in their system in addition to the alcohol. So crime labs consistently, especially in California, have not been testing their above 08 drivers, and this is merely because of resources. They don't have the technology, the staff, the facilities to do it. The National Safety Council has been making recommendations since the 2000s to basically test all drivers regardless of their blood alcohol level. If we know that nearly 40% of those drivers are going to test positive and we're not testing them, then we're not getting real prevalence data. So I'm here to encourage those who can to really change the ability for crime labs to do the testing, because the testing in and of itself will actually give you a true understanding of the drug driving problem in the United States. I work with an amazing team of individuals who've put some statistics together. I'm not going to go over all these pie charts and graphs because I'm short on time, but it's to show you that drugs are rarely taken alone. Many times as high as 25–30% of folks take at least 2 drugs or more in our apprehended drivers. And the graph on the right is actually of our median THC concentration. I'm not going to steal the chief's thunder on this, but we do some work on determining whether a per se is meaningful legislation. And I'm here to say, and I expect him to say the same, that in California, more than 60% of the apprehended drivers have a THC level less than 5 nanograms per milliliter. So, and this particular graph actually also shows you the distribution across the blood alcohol levels. Those levels go all the way up to a 0.35. So we have folks at low levels using marijuana, and we have folks at high alcohol levels also using the drugs in combination. And you can see there's not a real clear pattern about where they stop using. So polydrug use is pretty popular in our county as well. And I'm going to pass it on to the chief.
Thank you.
Good morning, everybody. Can everybody hear me okay? Excellent. It's a real honor to be here. Thank you, Administrator, for inviting me to come out and speak with this esteemed group of people here. And I would put a challenge out right now, since we're on a call to action, that the next one we have here is full of law enforcement leaders. I'm talking chiefs and sheriffs, because you heard John Lee mention that earlier. That's where we need to go. We need to get the engagement of those law enforcement leaders to take this traffic safety programs and run with it and protect our community. So that's the next challenge. A little bit about the Drug Recognition Expert Program. You've heard that a little bit today. For those that are not super familiar with it, it is a program that's managed by the International Association of Chiefs of Police, and it's been around since the 1980s. And currently, there's nearly 10,000 drug recognition experts, nearly 9,000 in the United States, 600 in Canada. I think they have a lot of work to do up there because they're getting ready to legalize marijuana throughout the entire country. They have 600 DREs. Those roadways come into the United States too, so it's not just a U.S. problem. It's a North American problem we're dealing with. But there's some of the finest men and women in law enforcement who take up the challenge to be law enforcement leaders. And John Lee also made another point there, and I'm not afraid to talk about it. We have to get our law enforcement leaders engaged in traffic safety. And this drug recognition expert program takes a lot of hard work to become certified in it. I went through it in 1992, and I'm still a drug recognition expert. And I went through all the ranks, and I've had all the assignments, and I still hold that certification. But what we hear in America is the DREs, once they get promoted or they move on, they're too busy. They don't have time to stay in the DRE. So I say, I'm pretty busy. I'm a pretty busy man, and I can stay as a DRE. So we have to put that challenge out there. The reason they get promoted is because the best of the best go into the DRE world. So that's my pitch on drug recognition. Let's talk a little bit about Colorado. Well, that's kind of what it looks like out there. I put that slide up there. I know there's a lot of Starbucks going around here in this building today. I visited them myself, but there's a lot of marijuana stores in Colorado. You can find them more than you can find the Starbucks. That's a picture of the state right there. You have a lot of liquor stores, but you have about 491 retail marijuana stores. You can get that drug just about anywhere in the state legally now. Not in all parts of the state, because the Colorado law allows some communities to opt out of it, so it's only in certain communities. So I've been fortunate to be a chief in a couple of communities, and we do not have dispensaries in our communities because our city councils have decided to opt out of that, but you can certainly find it. And let's just talk about that for a minute at the very bottom bullet right there for you. 107,531 medical marijuana registry patients in the state of Colorado. But look at the demographics right there. There's a lot of sick 21 to 30-year-old white males in that state. There's a lot. I thought that would go down a little bit when Colorado passed Amendment 64 back in 2013 and made marijuana legal in some form or fashion for people over the age of 21, but we still have a lot of medical marijuana card holders in there, and there's a whole variety of reasons for that. It's taxed at a lower rate. There's also a gap right there. If you're between 18 and 21, you can get a medical marijuana card. So you can still consume it at 18, 19, 20 years old, where legalized recreationals for 21 years old. So there's still some things to look at there. Back in 2013, Amendment 64 was passed in Colorado. It was not a law change, it was a constitutional amendment. So in Colorado, people that are out there have the constitutional right to possess and use marijuana. That's going to be a very difficult thing to overturn. It sounds like it's going to be part of the established culture in that state. And when that occurred, there was many task forces that were put together. One was through the governor's office. In this task force report on implementation of Amendment 64, there were two specific recommendations related to traffic safety. I'm going to put a slide up next. It's got a lot of words. You won't be able to read it, but I'll mention to you what it is. The first one was the passage of the 5 nanogram bill for THC. You just heard Jennifer talk about that. That wasn't a per se. It's not like a 0.08 per se. It's called permissible inference. That is extremely weak. That is a standard that a jury can get that information and really, okay, I agree with it or I don't, they can put it aside. So it's permissible inference. I warned many people not to pass that when it happened, but it went right through. There's a big lobby on the marijuana side. That bill went right through, and the 5 nanogram bill was passed in Colorado. That makes it very difficult for police officers to secure that blood from marijuana impaired drivers and have that THC level coming in at 5 nanograms or greater, because it does eliminate through the body very, very fast, and I'll give you the numbers in just a minute. The second recommendation came out of there was to fund A-RIDE. You heard about that today, and put that in law enforcement at a higher rate for training in the state. And that money has come through marijuana tax dollars now, and we are training a lot of police officers, troopers, and deputy sheriffs in the state in A-RIDE, and that was the second thing. That was a positive. But I caution you that when people that want to help law enforcement put these bills out there, they need to be engaged with law enforcement, because you'll hear some people that are very interested in helping saying, we want to get every police officer DRE trained. Well, that's not going to work. Really about 2%, maybe 3%, somewhere in that range are DREs of police officers. That could be a little bit higher, but it's excessive training, and it takes a lot to maintain the certification, and you have to have the passionate traffic safety people involved in DRE to do that. So, but the real key is a slide earlier from John Lee, is get those officers A-RIDE trained. This slide right here, when I speak about marijuana, sometimes it takes me a couple hours, hour and a half presentation. I spend a lot of time on each of those bullets there, so I just going to rip right through that, and we're going to focus on the last one, which is impaired driving. But we apologize to our neighboring states of Wyoming and those others, because they're diversion of marijuana. It's coming out of Colorado. I was a state trooper in Arizona for 20 years, and we knew when harvest season was coming out of Mexico, it'd just come right up interstates and be dispersed around the United States. Now it's grown and produced in Colorado and sent out throughout the United States, and it's on the increase. Youth usage is up. We can say we're number one. Adult marijuana use, emergency rooms are up. Marijuana-related exposures, treatment, THC extraction labs, and crime's up. Not my community, I'll tell you why in just a minute. And impaired driving's up. Positives. When this Amendment 64 was passed, all the police were upset. We were mad. We were mad. It's constitutional right now, so we had to figure out how to work through this. Let's talk about positives. Better training for DRE and A-RIDE in law enforcement. Now, we have funding through the state through marijuana tax dollars to train every police officer in A-RIDE. We have great dollars available to train DREs. Now, the city of Loveland's about 76,000 people in the community that I'm the chief in. And from 2017, comparing to the average of the previous 3 years, we had a 91% increase in DUI arrests, driving under the influence of drug arrests in my community. 47% increase in DUI arrests in 2017. Now, why is that? Well, they got a new chief. I came there 2 years ago, and I'm a traffic safety guy. My dad was Arizona Highway Patrolman. I was Arizona Highway Patrolman. That's why we have to engage our law enforcement leadership. If we focus on crime fighting through the data-driven approach to crime and traffic safety, we focus on impaired driving, our crime's going to go down. Look at that number right there. Our DUI arrests are increased. We've got a new focus on the department. Sure, it's tough. I had every police officer, every detective, every rank on my department go through A-RIDE in 1 year, 113 officers. What do you think I heard? Geez, that chief, he is crazy about traffic safety. Why do we have to do this? We're detectives. Well, guess what? The detectives are out in the field. They're going to and from their house. They're going to the restaurants. They're doing interviews, whatever the case. They're picking up DUIDs, and they're calling an expert to come in and help them with that case. And we're picking up a lot more DUID drivers during day shift now. So you can see the numbers. Our community is safer. That second part there, that 5 nanogram level, goes right to what Jennifer was talking about in California. 55 to 70% of our arrests for DUID are coming in under this permissible inference. So we have to get the blood out of those drivers as absolutely fast as we can, so that those blood results do not dissipate and we lose those cases. But those are hard to prosecute if they're coming in under the nanogram level, which is that permissible inference, which is already weak. Dr. Dupont, I heard you on the data collection. We're going to put some icing on that, and we're going to go with that. In 2016, you can see the DUID arrests by the State Patrol, huge increase in that related to marijuana. I got a 5-minute window, so I'm going to go pretty quick here. Put that slide up there for you. Statewide fatalities are up. They are up. We hear that. But nearly half of the DRE cases are related to cannabis. We're not here I'm not talking about opioids today, but we still have plenty of opioids in our community, and plenty of methamphetamine, and Talcott mentioned that as well too. What does Colorado look like for the DRE and A-RIDE? Well, we have 228 DREs, 40 instructors. We've had a 25% growth in DRE since the legislation of marijuana. That is primarily because of the public awareness, the increased funding to train our police officers. We're using marijuana tax dollars for that. All troopers in the state of Colorado, the State Patrol, have trained their troopers in A-RIDE, and they're doing wonderful work, as well as my department. That is a slide right there. I'm not sure if you can see it very well. It comes from the Department of Transportation that shows the increasing numbers from 2013 to 2016 specific to THC and fatally injured drivers on the highways, and you can see those numbers are increasing. Drive high, get a DUI. Has anybody seen this campaign out there? There's a few out there. The Colorado Department of Transportation has done a wonderful job messaging drive high, get a DUI. This has worked very well, and it's been in partnership with the marijuana industry. I'm going to show you 2 quick clips right here that are playing in dispensaries around the state of Colorado now. Go ahead.
I actually drive better when I'm high.
The police can't tell that I'm driving high.
Some of us can. I can. Those are being played in dispensaries around the state, because when you go into a dispensary in Colorado, you have to sit in a waiting room, you have to show them your driver's license, there's all these rules and regulations from the state. So instead of listening to somebody like me saying, don't drink and drive, don't use drugs and drive, they've got other people messaging in there, and they're finding some pretty good effects through that. It's pretty effective campaign. I'm just about to wind down here, but I put this slide up there to show you something that we did unique in Colorado. Now, I chair the Colorado Task Force on Drunk and Impaired Driving, and that is Glenn Davis from CDOT right there, and a lawyer from the marijuana industry standing behind the flying wheel of the Colorado State Patrol at a press conference. Partners there. A couple of years ago, our task force had a legislature open up a bill to change the name from drunk driving to drunk and impaired driving, and we added a few seats to our task force, and it's a statutorily mandated task force in the state of Colorado. There's defense, prosecution, there's treatment, there's prevention, there's a judge on there, there's sheriff's office, or sheriff's association, the chief's association. We have researchers, we have many people that come to state liquor that come to that task force, and we meet once a month. There's also members of the liquor industry there. We have on-sale premises, off-sale premises. We have representatives from Coors. We have people that are at the table there to help us with this problem of impaired driving. So a few years ago, when we opened up that bill, we brought on a representative from the marijuana industry. So now in statute, there's a member of the marijuana industry that sits on our state-mandated task force, and they work very hard to message to their constituents the dangers of impaired driving by cannabis specifically. We found that to be pretty powerful to do. It's outside the box, and I was one that at first was thinking, I'm not sure about this, but now we have liquor and we have cannabis all in there helping us with this messaging. And the drug dealer still lives in Colorado. That was a picture of 70 plants or so that I stopped by and took about a block from our city hall on the way home. These guys are growing marijuana in their backyard. They're selling it. They're producing it. They're not paying taxes on it. They're making a lot of money. It's very expensive to buy marijuana in a dispensary because it's taxed extremely high. But there's still plenty of people that are doing that. So I think it's important to realize that drug dealing has not gone away. And that's my presentation. I'm sorry it was so rushed. I'd love to talk about this and share with other states what we have going on, because Colorado is really, somebody mentioned earlier, the ground zero, and it really is ground zero for this. And I have a lot of information to share with you, and I think it's relevant to be ready, because it starts with the medical marijuana and then it goes to legalization, and you can see systematically that that's occurring throughout the United States. Thank you.
Good morning, everybody. And while they put up my presentation, I want to thank Jeff for the introduction. We talked a lot about tolerance today, tolerance to alcohol, tolerance to drugs. One of the jobs he mentioned that I previously had, I built a really good tolerance for people yelling at me. because I oversaw the State Department of Motor Vehicles for New Mexico for several years, and it was a very good crash course in tolerance. As a matter of fact, I don't even realize when people are raising their voice at me anymore. I have such a good tolerance. I am with the New Mexico Department of Transportation, and we have the Highway Safety Office under the DOT. I just want to share with you a little bit of background on New Mexico and our public education campaigns that we have done and why I think they've been so successful. And we are now diving into specifically drug driving campaigns, and I'll tell you a little bit about what we're doing. Our state traditionally, going back to the 1990s to early 2000, we have been in the top 3 and a lot of times number 1 worst in alcohol-related fatalities per population and per motor vehicle miles. So we are always top. We've been the top in pedestrian fatalities. We've been the top in earliest that a young person drinks alcohol, which has been 10 or 11 years old. So alcohol is very accessible, and we've had a big problem for a lot of years. You can see there back in 1979 when we first had the first full year of statistics, we were over 400 related alcohol fatalities. Our record low in New Mexico was a couple years ago, 2015, which is down to 120, and last year we're at 140. So we've made tremendous progress over the years, and I'm hoping that a lot of your states probably look a lot the same. But a lot of it has to do with the enforcement programs and then also some of the public awareness that I will share with you. Why is public awareness so important? And you probably can't read that, but it's from the National Institute of Health. Anytime you want to change somebody's behavior, mass media is so important, and how you couch the message and how you get into people's news and homes and how you change their opinions and their view of something is very important, and that's done through a lot of the media. I think a lot of us are familiar with the traditional media, TV, radio, outdoor, and as you know, social media is important in this day and age, and I'll share a little bit about what we're doing with that. But mass media, if you want to deal with this drug-impaired driving problem, it needs to be part of the solution, just like a lot of other things. I want to share with you a couple of our spots that we've done that have created a lot of the buzz early on in New Mexico. You're probably very familiar with the traditional message of enforcement. If you get caught, there'll be a consequence, and that research has shown those are very effective messages to discourage the people that are likely to do that behavior or are engaging in that behavior. We took that a step further. We still do those type of messages, but we wanted to involve the community. And as you know, it takes a village to solve this problem, and you need to get other people motivated and involved and let them know that you're also speaking to them. And how do you do that? You get some type of emotional response from them, that they want to do something, that they want to help end the problem. And so here's a spot that we did. Unfortunately, we didn't have to make up this scenario. This is something that actually happened.
911, what is your emergency?
I need help. Can you help me? I'm scared. My dad, he did bad things.
Tell me where you are and we can help you. We can get there very quickly.
He's been drinking and now he's driving.
Where is he driving?
I think we're on our way home. Can you help me?
Oh my God, you're in the car?
I'll show one more of this type of commercial, and there's no better way to get parents and other people involved when it impacts children. I think you've seen that probably over the last couple of days. But these are the type of things that have really got an emotional response from the community and really helped promote them to help with the problem, not just sit back and think it doesn't happen to them. One of our speakers mentioned it happens to all of us. We're all exposed to this, and certainly these kind of commercials tell the story of that scenario. And I think what's important about those type of spots is there were many opportunities in that last commercial for someone to step in and take the keys away or do something, and that's what we're trying to get to is don't be a bystander, get involved and help solve this problem that really obviously plagues all of our states. We have really started to hone in on very specific issues in New Mexico. Like a lot of states, we're working on texting or distracted driving. These are just screenshots. Buckle up, obviously, seatbelts. And then we're also really looking at the data and seeing what's important to our state. We, at one point, had about 75 or 80% of the arrests were all men. Now it's getting closer to a 50-50 arrest rate between men and women. And so we did address that. We had a whole campaign about women drive drunk too, and we need to reach out to them and what their issues are and try and prevent them from doing that. We had a very bad pedestrian fatality rate when a lot of the pedestrians were the ones who were alcohol impaired, and that it was due to over-service. We had a whole campaign towards servers called Buzzkill, and really supporting them when they need to cut somebody off. And our pedestrian problem went down in the particular areas that we were having the problems in, and we launched this campaign in. We obviously, underage drinking is a big thing in all of our states. Like I mentioned before, we had, the age where the lowest age where most people started to drink was in New Mexico. And in New Mexico also about 80% of several years ago were people that were in fatal crashes were first offenders, someone who had never been in our system before. A couple years ago we did a new study, and as it turns out, only 40% of people who have never been in the system before were causing the crashes. So that means 60% were repeat offenders, and we started to address that. And this is just an example of one of the spots that we did. And this spot particularly was supposed to support law enforcement because they were getting frustrated about having to pick up the same people or see the same people. After we did the campaign, and I want to say it was an educational campaign, not a lobbying campaign, we were able to pass legislation to increase our repeat offender laws because we were able to educate the public about this issue, and people got behind the issue that now a lot of the fatalities were happening because of repeat offenders.
In this job, I've seen it all. But some days, it feels like I'm stuck on repeat. Another day, another drunk driver. Sometimes the same guy, again and again and again. Until something changes, I'll be out here, doing my job, getting them off the roads. If they won't stop, I won't stop.
And like I mentioned, that was really important in us trying to educate the public so that we can get some support for the legislation that was needed. Our three main messages are DWI, texting, and buckle up. The reason I mention that is because as we move into this drug driving prevention campaign, it's really important to show and to confirm that the more investment you put in each of these issues, probably the more recognizable they will be. We did a motor vehicle division survey last year, and we asked people about, have you seen this, how do you recognize these campaigns? And 61% of them said they recognize NDWI, down to 11% for Buckle Up. This almost directly, perfectly correlates to how much money we invest in these public education campaigns. So as you can see, if you want to deal with the drug driving issue, you're going to have to put some resources in there so that people recognize the message and what you're trying to tell them. We also do a lot of social media, as I'm sure a lot of you do. Our next step is we are getting into the virtual reality. That's what seems to be where our millennials and other folks are learning. As you can see, virtual reality has up to a 90% retention rate, which is way better than TV or any kind of social media hit, because it's actually an experience for them and not necessarily having to read, but they actually experience it. And so we're moving into that realm to try and get our millennials involved. It's important because the millennials are basically our next, generation. And there's some statistics floating through here, but they definitely, as you all know, see things, get their information in much different ways. And so that's why we're heading into that realm. And I won't spend a lot of time on it, but if we're going to have any impact in drug driving, we need to make sure we address that population. So how does this impact drug driving? I'm very happy to GHSA about the drug driving report that they did. I took a look at that, and to be honest with you, I was really surprised just how many of our fatal drivers had drugs in them. I knew there was a drug problem, but I really thought it was really mostly alcohol, and to find that high of number of drug-related fatalities was really surprising to me. So I took a look and looked at our own fatality numbers in New Mexico, and this is only simply drug-involved, only crashes, fatal crashes. As you can see, not a lot from 2000 to 2013. I'm not blaming our northern neighbor, Colorado, but their law did go into effect in 2014. And I'll be honest with you, it's very common at this point in New Mexico for people to travel to Colorado. We don't have any professional sports teams. They have Denver Broncos and all those. They travel on weekends, and people actually take orders and go up to Colorado, purchase, and come back. And we're not talking about a few $100s. We're talking about thousands of dollars in cash that's given to someone. They go into Colorado for the weekend, they purchase for their friends, they come back and they hand it back out to their friends. And so that is something that very commonly happens in our state. For whatever reason, people feel much more comfortable that they're buying it legally in another state, even though it's being illegally brought back to our state and done illegally in our state. But that's a very common thing that happens. So what are we doing now in New Mexico? We have a DRE A-Ride program. As a matter of fact, we had a very good one that the International Chiefs of Police Association stole our DWI coordinator, Christina Frank. She's here, so we're having to replace that. But we do have a pretty strong program. We do fund our state scientific lab to do testing. We try and test as many things as many cases as possible, and we do a pretty good job in that. And we do fund DWI drug courts. However, we can only fund the ones where the person was convicted due to alcohol. We can't do drugs just because of the type of funding. And I'll talk a little bit about that in just a minute. What are we working on? We are working on legislation. We've tried to set some type of limit, whether it's a no tolerance, which would be the best thing, or some per se. As you know, there's just not research out there to support that. Birchfield, for those of you who know what that is has impacted our state a lot, which means you can't enhance a penalty for someone refusing a blood test. Well, in New Mexico, you can't get a search warrant for a first, second, or third offense because it's a misdemeanor, so there's really no penalty right now for someone who refuses a blood test for a first, second, and third offense. So that's really impacted us, and we're trying to address that through legislation. We have a strong enforcement program, and then, of course, our public awareness campaigns. Part of what we're doing before we start, and we're in the process right now, is look at other campaigns. California has their campaign, Colorado that you saw a minute ago, but we're also looking at other countries. We're taking a good look at New Zealand. They're doing a lot of good things as we start to develop our campaign, which should be out this summer. And the last thing I'll say is, what can we all do to help states from our local level perspective? First of all, good GHSA and NHTSA leadership. I'm lucky to have Jonathan and Jana at GHSA who are made this a priority and are really springboarding this issue forward. I'm really happy Deputy Administrator King had put this together. I've heard nothing but good things. And so I think we have the leadership in place right now to springboard this issue forward. For those of you who run highway safety offices, you know what I'm talking about, Section 154 and 164 changes. That's the type of funding that a lot of states get for DWI, or specifically alcohol. I can tell you right now, my federal budget is $12 million. Half of that, about $6 million, is Section 154 or 164 money. But it's really restricted, at least right now the interpretation is, to alcohol, and you cannot use that for drugs. If you were to open that up to be able to use that for all impaired driving, it'll really help the states be able to purchase the types of things that are needed and invest in the type of things that are needed, such as equipment, roadside testing equipment, and those type of things that we can't purchase at this point. And I heard Dr. Hedlund mention this, per se limits, and I put in there, thank God I put this last part in there, as research supports, because I know we can't do that for a lot of things, maybe not even very many things, but if we could at least get something, anything, I think that would be helpful. We've been trying to pass some stuff in our session, and they always go back to the research, and right now there just isn't a lot that would support per se, but if there ever comes a time that happens, that would really be helpful to our states in helping us pass some legislation. So I believe my time is up, and I appreciate your attention, and thank you guys.
Well, there's nothing like going last with such amazing and esteemed speakers. Good late morning to you. I'm Frankie Tack. I am a clinical assistant professor at West Virginia University, and I bring you greetings, unfortunately, from opioid land. But I also bring you greetings from your fellow warriors in this work, and I'm always glad to find my people wherever I go. So whether you came here because someone asked you to, or because you have a passion for everything involved with safety, drug awareness, whatnot, you're now one of the tribe, so I hope you'll find some inspiration to go and do the work today. My role is kind of multifaceted at WVU. I'm not a researcher. I come from the clinical side and have been an academic for 8 years, but prior to that was worked in clinical substance use disorder treatment for many years. And what I'm doing now is working to build programming to train clinicians so that we can build our treatment capacity. And I'm gonna touch on today more the back end, if you will, from what many of you all are dealing with in terms of what do we do to help prevent recidivism, and a little education maybe for some of you who may not be as familiar with substance use disorders and addiction and how that all plays into this. So we have a big treatment capacity problem in this country. We had it before the opioid epidemic. We had it before medical and legalized marijuana. And it's only getting worse by the day. And as we all become empowered to go and do more work on this issue, we're going to be putting more pressure on the treatment system. So my little blue sticky over there, which I did make over to, I guess, the Health Medical Board, will be advocating for increased treatment capacity in your communities. So I hope as you get the opportunity to speak to decision makers and policy makers, or if you are one of those people, that, that you begin to advocate for the back end, because I think that's critical. And the other thing, I just want to acknowledge Dr. DuPont one more time. I felt like I've met Elvis, you know, if you work in my field. It's just, oh my gosh. It was worth the 8 hours round trip driving just to meet you, sir. So I appreciate we stand on your shoulders in this work, so thank you. So I'm going to talk a little bit about some of our current clinical best practices relative to those with DWI, but I'm mainly going to focus on, and that's just going to be a little tiny touch just to kind of get us all on the same page, but I'm mainly going to focus on this question of recidivism and how the treatment side or the clinical side can help with that. So, so our current protocols, I'm sure many of you all know, is that once a person's adjudicated, or depending on the state or the attorney, they may have some pre-adjudication stimulation, no pun intended, to seek substance use assessment. But there is a comprehensive psychosocial assessment done. And I think most states require certain minimal credentialing for the addictions professional required to do that assessment, which is key, because mental health assessment in general is a challenge, but when we get to the shall we say, dissimulation that can come with people with substance use disorders, that is just denial, lying, manipulation, etc. We need an extra set of skills to work to get to an accurate assessment for that person. So accurately assessing, determine if there's a clinical diagnosis or not, and then referring for appropriate intervention and referral based on that assessment. So we don't take a one-size-fits-all approach. We're referring to based on what that assessment shows. A person who has made a poor decision but does not have a substance use, drug use disorder does not need to go inpatient for 28 days, for example. But a person with a severe addiction also doesn't need to go to DWI school. So we've got to be able to striate our population and realize not everyone that gets
a DWI or a DUID or DID is the same. They vary significantly, and our response needs to vary accordingly. So intervention planning, and then referral to appropriate prevention, early intervention, or treatment programs. And that on the treatment side, or early intervention, but mainly on the treatment side, using our American Society of Addiction Medicine levels of care criteria, which is a well-established referral model. And so your partners in your community should be using ASAM levels of care when they're making their treatment referrals. So that's something to check, especially for you drug court for your drug court partners. Then having good wraparound services, case management, and good integration with whoever those criminal justice personnel are that involved. So community corrections, whether it's an active prosecution underway, if they're involved with drug court, whatnot. We're going to see better outcomes where all the collaterals around that person are working together, are talking to one another and on the same page. Particularly, again, where a person has an addiction, we know there's a lot of playing one against the other, not telling everybody everything, telling certain things over here and not telling them over there. So we all need to be pulling in the right direction and same direction to help somebody get better and thus reduce their recidivism. So just again, to kind of talk about how we look at who gets the DWIs. So obviously if a person's not using drugs or alcohol, it's impossible to get a DUI. And so we certainly are, in our prevention programmings, I think there's a lot of advocacy for not engaging with substances to start with, and that's an important part of the work. Now, people who use socially, that is, they use in limited ways that don't produce consequences on a routine basis, could get a DUI or a DUID. Less likely, however, by definition, they're using in a controlled manner and making good low-risk decisions most of the time. However, that doesn't mean they aren't from time to time going to misuse, which is our next category, which is infrequent overuse or using substances that, or prescriptions that aren't prescribed to them. So, you know, New Year's Eve is my best example of misuse. You normally don't drink heavily, or you normally, maybe you smoke a little marijuana here and there, maybe you take a prescribed Xanax, PRN, but for some reason, today you're with your friends, it's New Year's Eve, you drink way more than you normally do, a bunch more joints are going around at the party, you smoke more than you normally do, or you've had a really rough week at work, so you take a couple extra Xanax, and you get into trouble being impaired and driving. So that person is different than people that have addiction or are substance use disorders. And we characterize substance use disorder itself on a continuum from mild, moderate to severe. And again, I'm saying DUID very likely that they are driving under the influence of drugs, not necessarily very likely that they get caught or prosecuted. You all know the statistics on that. I think it's something like 100 times a person drives under the influence, and I don't see any reason why that would be less with drugs. Matter of fact, I suspect it would be more. And I don't know if we have those statistics or not, but maybe they'll pop out at some point. So when we're looking at what substance use disorder is, it's interesting in that when we want people to not recidivate on DUI, if they have a substance use disorder, by definition, they are continuing to use despite significant consequences. That's literally the definition of what substance use disorder is, and that includes legal consequences. So we have this conundrum that we don't want those people back out there, and yet they're the ones most likely to go back out there. So for people in the use-misuse category who get that DUI, it's like the hand on the hot stove. Oh, I put my hand there. Ouch, that hurt. That cost me a whole lot of money. I was embarrassed in my community. I couldn't drive for a while. I had to hire an attorney. My spouse is chewing me out, etc. That was really painful. I don't think I'll do that again. I'll change my decision making. Well, a person with use or misuse has the capacity to do that, but a person with an addiction, particularly a moderate to severe addiction, doesn't. This is the picture that I was not sensitive enough to not include. I don't think before these people went to SCORE, which is what happens with opioids, they drive their car to SCORE to get their drugs. They're so desperate for the hit that they sit down in their car and shoot up and then think they're going to make it home. That's seriously impaired decision-making on every level. And as the two good doctors this morning said to us, it's because of what's happening in the brain. Why they use the pleasure centers hijacked, the prefrontal cortex is completely impaired. We know the prefrontal cortex, our executive functioning, our planning and decision-making part of our brain, does not function when people are in moderate to severe addiction. And so they do things like drive their car to SCORE with their 4-year-old in the back, get in the car and drive, and nod off behind the wheel and crash. So here are the diagnostic criteria for substance use disorder. Obviously, you can't see them. I'm not going to read them all, but what I would like you to be aware of is our diagnostic manual clusters these into 4 key clusters. And when you look at what these clusters represent as far as the potential for driving under the influence of drugs, well, it's most of them by definition. And so I really think that what this leads us to, what this leads us to is that from a recidivism standpoint, we must have a robust intervention at the point of the original arrest. I'm a great proponent for drug courts, and we've got to link people to treatment, and we've got to get them to follow through at that point. I have experienced many people with very old DUIs, and again, Jeff had asked me the question, do you think people who use drugs are different than people who use alcohol relative to recidivism? I don't think so. I don't think so. The drugs differ, but I think recovery is a challenging process for anybody regardless of drug. We know it's a relapsing disease just like every other disease we have, just like heart disease, just like diabetes, it's a relapsing disease. And so I don't think there's going to be a big difference there, but we must get people linked to treatment. And we need to encourage those that don't follow through for that assessment that they have to do to get their license back, to do that. I don't think that's something we currently do now from a I don't know if that would be illegal on the legal end, but we have plenty of people that come back 8, 10 years later to get their assessment because they want to get their license back. Well, what have they been doing in the meantime? I seriously doubt they've been on a moped for 8 or 10 years. I'm sure at least some of that time they've been driving. Now, I think we need to find a way to reach out to those people. I bet all of your states and all of your jurisdictions have people who are languishing, who got that first DWI, lost their license, went through their process, whatever. They don't have their license back, but that also means they haven't gotten the treatment or intervention that they likely need. So I think that's a place we can do some work in the future. Again, advocating for treatment capacity in your communities is going to be extremely important, especially when we look on this back end, on the recidivism end. We've got to be able to intervene with these folks. We don't have the professionals to do that now, and in some states like mine, we literally don't have the facilities. We're literally trying to build enough buildings to do the work. So the last thing I would add, if you want to go off and read a little something that might help bridge we were talking about bridging from research and theory into practice, is that we have a big focus in addiction treatment on motivational theory and on stages of change. And I think this applies as well to the front end for prevention and those you're interacting with, early intervention in the court systems. We try to drag people from not thinking about it at all to change. There are a lot of steps in between. So if any of you are curious, to check in and read a little bit about motivational theory and stages of change, I think it might have a lot of good translation into what you're doing. So with that, I'll relinquish the podium. Thank you for having me today.
thank you all. Terrific presentations, very stimulating. So, do we have any urgent questions? Okay. Please.
As you all talk about best practices, you talked a little bit about public awareness campaigns, and we saw some of the videos that you're doing in different states, but none of you talked specifically about what's going on with school-age children, whether they be in middle school or high school, and what type of public awareness you're doing with students now to talk about drug-impaired driving and the issues that they will face by driving under the influence of drugs. Can any of you speak to that, if that's going on in your states and what you're doing with school-age children to educate them?
That is something that I think, at least in our state, we haven't delved into at this point. We did just develop a pretty strong, comprehensive underage drinking campaign where teachers have curriculum and all of those type of things. And part of the issue for us is funding. Like I mentioned before, we have a big pool of money that we could use for alcohol-impaired driving. But once you get into drug-impaired, our funding resources shrink, and we have to make decisions how to best use that. I think it's a really good opportunity to try and establish that with our young folks, especially millennials, because they seem to have a little different attitude when it comes to like rite of passage and stuff. They're not as much into that, and so I think it's a good idea to try and change their culture so that it passes on down to the people that they end up bringing up. But right now we don't do a lot as far as drug in the school-age children.
Hi, if I can respond just briefly for Colorado. The media campaigns that I put up there, they're trying to address the demographics of that driving population and the known users in that particular age category. So not a lot, as you mentioned, but it's a great idea. But the focus has been on the younger driving population.
Yes, a question for Jennifer. Thank you for what you're doing. I was pleased to see that you're doing the testing of drugs on all DUIs now. That's a very important step. That doesn't come for free. So my question to you is, how did you generate the cash to support that? And more importantly, how did you develop the support to be able to take on this initiative?
It's a question that I get fairly frequently. We're really lucky to be well supported in our county. So our sheriff has seen this as an important thing to be doing. So between our budget with our sheriff's office, through grant funding, through the Office of Traffic Safety, we've been able to fund the technology. We have some incredibly bright people who work for us who have been able to do the work to get it developed, and we're sharing those methodologies with the rest of the state of California to try to help other laboratories do the same. But the way we got the technology initially is we got some of it through grant funding, and then our county supported additional efforts after that. We've also used asset forfeiture monies through the Sheriff's Department in order to continue to maintain the equipment. But to say that I'm well-resourced is an understatement, because compared to my colleagues, we certainly are.
Thanks, Jennifer. Really good presentation. I was a little unclear, and I wondered if you could possibly elaborate. It seemed like you were saying that you were using your relatively vast testing technology and capability in collaboration with law enforcement to see whether there were some impairment levels that could be considered, maybe standard. Maybe that's the wrong word. I wasn't sure if that's what you were saying.
Sure. So we have two publications that have been put out through the Journal of Forensic Sciences that specifically dealt with THC concentrations, blood concentrations in drivers. We did a multi-year study looking at both DRE and non-DRE DUI cases We looked at not only their reporting of the field sobriety tests, but objective signs and symptoms, and also our blood testing. We wanted to ensure that when we were looking to see, could you correlate a level of impairment based on the standard markers that are currently being used, standardized field sobriety test, objective signs and symptoms, some physiological factors that the DRE program uses, to a level of, or a blood concentration in those folks. And what we did was we did extensive comprehensive testing to ensure that we eliminated the most common impairing substances so that we could isolate the THC-only cases. And there was a publication in 2016, and then we just published again this year on the physiological factors. And I'd be happy to get any of that information, those references, to anybody who's interested. I know Chuck Hayes is here as well from IACP. He did a similar study with Dr. Marilyn Hustis. So those are two studies that I'm aware of that have come out that are, they say very similar things, that the protocols are working. They do help in identifying impairment, but to determine a level that the impairment is going to be caused by is not something that we can currently do.
Hi, Elvis Oxley. So pleased to meet you, Doctor. 6 generations ago, the world was blessed with Heinrich Draeger, who invented the Lubeck valve, which turned into the first beer tap. 5 generations after that, another Draeger invented the interlock device. So full service company, obviously. There's now the Draeger Drug Test 5000, which is a toaster-sized box that goes in the back of a police vehicle that has a red light and a green light on 8 very specific drugs. The pushback that we've gotten for the counties that have used this device is that it's fantastic. However, in court, there is no .08 on the drug side. So I appreciate your research on this, and I would love to know more. What are you all on the panel doing with your legislators in order to promote whatever the drug version of the .08 is, so that there's an absolutism behind the data that we can get in the field, so that we can do essentially what MAD has done on the drunk driving side for the drug driving side?
I can say in California there's been a big push to try to identify whether a per se law is helpful, or to identify a level in which you can basically say that somebody is impaired. Certainly our data is readily available to those legislators to understand that maybe that isn't the best way to go. Maybe they should be looking at zero tolerance. There is a lot of data that has been put out by many organizations, including NHTSA and the AAA Foundation, that supports maybe a different way to go. So our intent as a group of crime labs, I work with all of the crime labs in the state to try to ensure that our policymakers have evidence-based information before they go forward with policy. And whether that be on technology that is being considered, or whether that is looking at a particular level, we try to just educate based on what information we have, and we share that information.
Thank you. Ed, did you have a question? Oh, okay. A question for afterward. Well, let me then. We have a question back in the corner.
Help because a lot of these pictures are very familiar to me, responding to accidents and whatnot. I'm just wondering, is there any state with a great example of that communication between EMS, fire and EMS, and getting these people to further health or further help or something like that?
I don't know that I can say we'd be a model in any way, but you know, with a lot of EMS and use of naloxone and with opioid overdoses, that conversation happens every time they revive someone. The problem is there's a very low rate of people with an interest in seeking treatment at that point. Most people refuse transport, which I'm sure I'm not telling you anything you don't already know. Most people refuse transport, and matter of fact, they are often mad that you've ruined their high, and they want to go get some more and use again. So, you know, and there have been lots of different things talked about with that, and I think, you know, this gets into how can we address that problem without limiting people's rights, because, you know, it also comes into things like, well, maybe that's a warrant for involuntary commitment, or, you know, reducing the number of transports, or we're only going to revive you a certain number of times, or things like this that also get into the stigma surrounding this, because we certainly wouldn't withhold treatment from someone. As one EMT I know told me, he had done multiple runs a week on a lady who had advanced stage COPD, had oxygen and a cannula in, smoking cigarettes, but we weren't talking about involuntarily committing her or saying we won't respond to her again because she won't seek appropriate treatment or stop doing the behaviors that are exacerbating her health and causing the EMTs to be called repeatedly. But I think there's a great push there. The challenge is at the low motivation at that point.
Thank you. I think we're at our lunch break now, but we're coming back, and for instruction on how to handle your lunch break. We have an excellent cafeteria. Thank you.
I should brought bread and peanut butter. So thank you, panelists, very much. That was absolutely fantastic, and I know we could go for days, and I wish we could. I wish our bodies would allow us to. So here's the plan for the rest of the day. I think many of you saw the agenda, and it looked kind of mysterious, like activity in the afternoon. And that's because we knew that we would be learning from the speakers today, and we'd be learning from you, and I wanted to adapt. So here's what I think we'll do, if you agree. First, we'll take time for lunch and restrooms. Restrooms in this building are in the four corners, men's and women's. There is a cafeteria that's in the building. If you walk this way, you can go downstairs and under a walkway and then up into the next building. There's a cafeteria there. So please enjoy the food. I think if you leave the building, it's hard to get back in. Caroline says, yes, if you leave, you can't get back in. Here's why I want you to come back. I want you to come back to NHTSA. I have the things that I think we should do. I don't know if they're the right things. As I've mentioned to you earlier, I've been at NHTSA for less than 6 months. You are experts in the field. You're experts in what works. You're experts in what doesn't. We have laid out a plan for what we think we should be doing next. I want to share that with you, and I want you to react and say, oh my God, Heidi, you're missing this and this. So I would like to look at your ideas on the boards. I do encourage you, please, even if you think it's a silly idea, if you think it's too small or too big or too early or too late, write it down anyway. We desperately need all of our thoughts, brains, and commitment on this journey. So share your ideas. Use the restroom, grab some lunch, come back. I will share what our plan is at NHTSA. You will please, I hope, feel very open and comfortable in a trust conversation to tell me whether you think we are proposing the right approach or whether there are things we should be doing in addition or doing differently. And that's how we'll close our day. When we leave here today, we will have a plan of action. When we called this a call to action, we weren't joking. So thank you all for a fantastic morning.